Check, check, check. Woo! It works.
How are you?
So
The stream is up. Good morning. Hello. Is this thing on?
yeah, it's on.
Okay. I usually am a loud talker. Hello, good morning. I don't think this is on. Hello? Hello, good morning.
Morning.
Good morning. Can everybody hear me in the back? Is this thing really on? Yeah. I'm usually a really loud talker. Shh, nobody laugh. But hopefully you guys can hear me in the back. So welcome to the Critical Care Conference for 2024. It has been, gosh, I don't know, 6 or 7 years, I think, since we've had a Critical Care Conference. It's been several years. And I really wanted to bring this back to the institution. I think it's a really great learning opportunity for our ICUs, for nurses, respiratory therapists, pharmacists, doctors, nurse practitioners, and whoever else I missed. Who else did I miss? That's everybody, right? So welcome. I also wanted to say Happy Nurses Week to the nurses in the room. I'm missing Meatball Day in Open Heart, and so I'm very sad about that. I know Dylan probably is as well. And then this month actually is Critical Care Awareness Month as well. And so we're going to have a special snack this afternoon that's sure to turn your teeth blue. Some of the suggestions that SCCM, the Society of Critical Care Medicine, has for critical care awareness is to wear blue scrubs. I think we got that one covered, most of us. Blue snacks, blue decorations, but also to share our gratitude. So video tributes, shout outs, share your why. And, I think it's really important to share our why about why we do what we do. It's for patients and to get them better and hopefully get them back to their families. And to see patients get better is such an amazing reward for us, I think, all of us. So I also want to, on that note, thank you to the village that made this happen. And it was not a small village. And so we had quite a few people, too many people to name individually, but all of these people helped in some way to help make this day possible. And so I really want to thank everybody, particularly Julie for helping do all the organization, and Jessie for her mad spreadsheet skills with all the breakout rooms this afternoon, and Jay for helping out with all of the technical stuff, all the flyers and all the things that have to be done. So with that, I'm going to turn it over to Julie.
All right, good morning. So this is our agenda for the day. We will have our speakers this morning in this room, and then we will break for lunch at about 12:15, and that will be in this room. After lunch, there will be 2 of the breakout sessions are downstairs. So family rounding is in this room, and the Michigan Lung is down the hall. The rest of the breakout sessions are upstairs, and we will be up there to help kind of guide which way to go. In order to get your continuing education, on each table there is the to scan and complete the evaluation, and then that way you get your continuing education credit. All right. So, does anybody have any questions about how the day will go? All right. So our first speaker this morning is Dr. Ely. Dr. Ely graduated from Ohio State Medical School and then completed residency in internal medicine and pediatrics. She completed pulmonary critical care fellowship at University of Kentucky and has been at CAMC ever since. Dr. Ely has been the co-program director of our Meds Peds residency and started our pulmonary critical care fellowship in 2020. She then became the division chief of pulmonary critical care in 2022. Dr. Ely is involved in many ICU and pulmonary initiatives and research publications with her interests in lung cancer, pulmonary hypertension, cardiovascular, critical care, and today she will be reviewing the ABCDEF bundle and the evidence for its use. So, welcome Dr. Ely. I know.
All right. I like to pace, so we'll see how this goes. Hopefully I don't mess anything up, but our objectives today, so everybody can hear me. Can you still hear me if I'm doing this? Yes. Oh, I talk too loud. All right, so our objectives today for this hour, this is really going to be an overview of what the ABCDEF bundle is. They keep adding letters. It used to be just the ABCD bundle, I believe. And they added the E and the F in the most recent PADIS guidelines to really emphasize early mobility and family engagement. So we're going to review what that is, what it entails, and we're going to discuss each of those elements and what it means for all of those things. When we talk about the elements, we're also going to go over the evidence for each of those. Now, it's really hard to talk about just evidence for one particular piece because oftentimes these things were studied in the bundle. But a couple of them do have evidence just for that particular thing. But we'll talk about the outcomes, and then we will talk about ways to implement this in your ICU. So what are the ABCDs? Why do we do them? The SCCM, the Society of Critical Care Medicine, has a huge amount of resource out there for toolkits to help introduce this to ICUs and to help initiate and implement some of the initiatives that are part of the bundle. Using the bundle has been shown to improve survival in the ICU, improve length of stay, which also improves our costs, which we know is the bottom line for some of the people in the institution. It's not really ours, but we care about costs too. It can't cost $1 bajillion, but we want better outcomes for our patients, right? Using the bundle decreases vent days, improves delirium and coma, actually improves restraint-free care, and I know that we all care about that. It decreases readmissions. It helps people get home. And so instead of discharging to a rehab facility, it helps actually get those people home more independently if we start mobility early. There's something called post-ICU syndrome. So people that go home, patients that go home after an ICU stay, a lot of them have complications, not just from a physical standpoint. We all see their weakness every time we're in the ICU. They can't hardly move. They can't get up and stand. Some of them can't feed themselves. It can be pretty profound. But that person also has cognitive issues that happen for long after, and also psychological ones. And so that whole sort of constellation of symptoms after the ICU is called post-ICU syndrome, or PICS. Implementing the bundle also improves standardization of process. You know, you're not asking, is Dr. Ely on? Do we have to do this? Is Dr. Ritchie on? Do we have to turn the lights on? Is somebody else on and we don't have to worry about that? And it improves team communication. So all of these elements help improve team communication, but we'll specifically talk about the F part of this bundle as well. So the bundle, they sometimes, you know, with acronyms, you have to get really creative. So A is for assessing, preventing, and managing pain. B is for both spontaneous awakening and breathing trials, and I just think about them as breathing trials because that makes more sense to me, but it's both SAT and SBT. C is the choice of analgesia and sedation, so the choice of your agents makes a difference. D is for delirium, so assessing, preventing, and managing delirium. E is for early mobility and exercise, and F is for family engagement and empowerment. The most recent guidelines that came out from SCCM, so it used to be the PAD guidelines, the pain, agitation, and delirium guidelines, and in 2018 they added I and S. So I stands for immobility and S stands for sleep. And actually sleep is not part of this. You can see, I guess they can't figure out a G that goes with sleep. Good sleep, that seems like that would go. See, maybe I fixed their problem. But integration of good sleep hygiene is really key to many of these things, but particularly delirium, as you can imagine. We see our patients getting crazy at night. They're also crazy during the day. And so maintaining that sleep hygiene while they're in the ICU, which can be hard, actually will improve a lot of their symptoms and their outcomes. So we're going to go through A first. A is for assessing, preventing, and managing pain. So the International Association for the Study of Pain, you knew there was such a thing, defines pain as an unpleasant sensory and emotional experience associated with acute or potential tissue damage or described in the terms of such damage. So that's sort of a mouthful. But what this definition allows for is the experience of pain to be multidimensional, and it's not purely a physical pain. There are 5 million ICU admissions every year. Half of the patients say that they have pain at rest, whether they're a medical patient or a surgical patient. So we always think about physical pain. With our surgical patient, that can be neuropathic pain, post-procedural pain, incisional pain, traumatic pain. But medical patients also have pain too, and that can be from ischemia or inflammation. Their pain is usually exacerbated by many of the things that we do to patients in the ICU. They're not able to communicate. Anxiety starts to get a hold, and you sort of spiral out of control. And so pain will actually make all this, anxiety will actually make all this worse. 80% of patients complain of pain with procedures. And those are procedures that you would think of like arterial lines, chest tubes, that type of thing. But they also have pain with mechanical ventilation, suctioning, repositioning. So some of those things that we sort of think, oh, we're just moving them around, we're just flipping them from, we're just doing the side to side thing, they actually have quite a bit of pain with. And I know some people, we can see them grimacing, but all patients actually probably have that, 80% of them. Pain actually increases mortality, and it's significant, 2.5 times, 2.6 times increased mortality if patients report a significant amount of pain. When patients are surveyed, 80% recall that pain was the most traumatic ICU experience that they still remember. 40% still recall that at 6 months, so it's something that sticks with them. And then 20%, because it was such a traumatic event, are actually at risk for PTSD. And that goes sort of into that PIC syndrome, that PICS, post-ICU syndrome that we talked about earlier. So the PADIS guidelines recommend a stepwise approach. The gold standard is to ask someone, do they have pain? Remember, 50% of people have pain at rest. And so if they say they have pain, they probably do. If they're not able to self-report, a lot of our patients are not able to, look for behavioral changes. We're trained to look for grimacing and things like that that will note that the patient has pain. Ask their family, if their family's there, does it look like they're in pain? They know their family member obviously much better than you do. Although you guys are around them all the time, they may notice some certain things that they do, some mannerisms that they do that would indicate that they have pain. Assume that they have pain, right? Assume that they're gonna have pain when we're putting in an art line, when we're doing a dressing change, when we're doing these things to them that we know cause pain. Assess frequently. So the PADIS guidelines recommend that we assess pain every 4 hours and that we reassess them an hour after we've given them treatment. There are several different tools out there to assess pain. The numeric rating scale that we have for patients that are able to tell us a number. The faces pain scale, we all see the happy faces and the sad faces. We have our critical care pain observation tool, the CPOT tool for those patients that are intubated and not able to communicate verbally. And there's an Oucher scale. That's really cute for pediatrics as well. And faces works for pediatric patients as well. The guidelines from PADIS say that prevention is key, right? Doing non-pharmacological interventions will help their pain. Having family around will help their pain, making sure that patients are distracted, and if they have a surgical procedure, that we've done everything that we can to optimize that, pre-procedurally treating them if we're going to do something that's painful. And then intervention, you can see a lot of non-pharmacological interventions there, relaxation, distraction, education, just telling them what are the expectations with what I'm going to do to you right now. Because sometimes just the not knowing what's going to happen, and then all of a sudden, oh, that doesn't feel very good, it's going to exacerbate things and make things worse. Massage. We can give our patients massages. We can play music for them. We can bring, what's our pet dog? What's our therapy dog's name? What is it? Cactus Jack. Could bring Cactus Jack around and have that be sort of their release. Again, having family there. IV opioids are the first line for non-neuropathic pain based on the PADIS guidelines. So if you have pain, treat pain. If you have neuropathic pain, treat them more with agents like gabapentin and things like that. Keep forgetting I have the clicker in my hand. B is for spontaneous awakening and breathing trials. So the B element focuses on really coupling those two things together, and that's why both is what's emphasized here. So the element focuses on setting a daily time each day, every day, to stop sedation, orient the patient to time and day, and conduct a spontaneous breathing trial to liberate that patient from the ventilator. Doing an SAT and an SBT together reduces hospital length of stay. Hospital length of stay by 3.1 days, which is huge. It's huge. We're on all these committees about length of stay right now, and getting patients off the ventilator is a huge factor into that. It reduces ICU length of stay, I might have that backwards, but ICU length of stay 3.5 days. It's somewhere in the 3-day range. That's my point. It reduces delirium by half. So if we're doing daily SATs and SBTs, delirium will go down by half, which also affects outcome. Oftentimes when we're treating patients and we're sedating them, particularly in those patients that are on extended sedation, a few days later, we're into day 5, day 6, day 7, we start to wonder, are they in there? I haven't seen them do anything for a while. And then we stop sedation. It may take a while for it to wear off. The next day comes, you're like, oh, we need a head CT. What is going on? We're doing some things to them because we've given them so much sedation, they're not wearing off. And it's not wearing off and they're not waking up. So a third of patients have diagnostics for acute altered mental status change that are not necessary. And And they've shown about 2/3 of those don't really show anything. You know, it's a normal head CT. How many times do you go down with somebody that's not waking up that your head CT is normal? We got our steps in though, didn't we? One of the fears is, I don't want to put them on a spontaneous awakening trial. I don't want to stop their sedation. They're totally going to self-extubate, right? So the literature shows that patients do not have a higher incidence of self-extubation. And also doing SATs and SVTs decrease ventilator-associated pneumonia rates, which is another outcome that we are always concerned about. So the PADIS guidelines say that there's synergy between SAT and SVT. Obviously, you can't have an SVT without an SAT most of the time. It requires a village, just like this conference, right? It requires the team to really assess them and to do the things. You know, Caleb can't put the patient on a spontaneous breathing trial if the nurse hasn't done a spontaneous awakening trial, unless you want him starting touching the drips, and I don't think you do. So it requires a team of providers. Is there some reason that we don't want to do it? Those reasons better be good. Requires the nurse, requires the respiratory therapist, and it requires a physical therapist too. The PADIS guidelines recommend safety screens, and they also give indications for failure. And so an SAT safety screen, and this is part of our protocol that we have here. Our SAT safety screen wants to make sure, do they have any evidence of increased ICP? Do they have seizures? Are they going through active alcohol withdrawal? Those are all things that maybe we don't want to stop sedation, right? Maybe we want to make sure that they have burst suppression because they're in status. If they're on paralysis, we don't want to do a spontaneous awakening trial, right? If we've put somebody on a spontaneous awakening trial, we've stopped their sedation, then look for signs of failure. Are they in respiratory distress? Are they breathing fast? Are they using their accessory muscles? And similar for safety and failure is on the SBT. So we're looking for, are they already hypoxic before we start the trial? Are they not breathing? Are they on high doses of pressors? Because that may make a difference. And do they have an increased ICP? And the same things for SVT failure. Do they have a new arrhythmia is a difference? Tachypnea, hypoxia, altered mental status, and respiratory distress. The Wake Up and Breathe initiative was one of the first things that Vanderbilt came out before even the PAD guidelines, I believe, that really tried to focus on the SAT and the SBT and coupling them together. And so when we developed our protocol in the way back time, you can see that much of our protocol was actually developed based on these guidelines. So you can see all of the alcohol withdrawal stuff, the intracranial pressure, respiratory rate, is their FiO2 50% or less? Is their PEEP less than or equal to 7.5 or less? I know that that's a sticking point with that little clicky box that you have to fix, that you have to click with your SAT screen. But our protocol was based on these guidelines. The other thing that SCCM stresses is you need to assess your patient daily, even when it's contraindicated. And because doing it daily gets you in the habit and you won't miss a day. And so oftentimes it's one of those things that, it's ordered and the nurse is asking, are we doing that today? Well, we should do it every day. That is a thing that we do every day. We should always screen them. If they don't have a contraindication, then they should go to the next step. The literature shows that asking me slows the process way down. Having you all take control of that situation and saying, well, the patient passes the SAT screen, they pass the SAT trial, they did great on the SBT. Hey doc, can we extubate? And I'm like, what? Is there a reason not to? I guess yes. Thank you for extubating my patient. That's great. But if you wait on me, it's going to be like 3 days before I even know what's going on. I'm like focusing on the antibiotics and the suppressors and like what's going on and have we talked to family? Do I have this person central line in? All that other stuff. So literature shows you guys do a great job with this. We do bad. Not bad, just we're slow. So C is for choice of analgesia and sedation. Medications matter. So the amount of medicines that you use and the actual medication agents themselves matter. Patients that have deep sedation, so that their RASS is -4 or more, or less, I guess, have a 2.6 increase of 2.6 times, so 2.5 times more mortality than those that are lightly sedated. And so that's a big deal. Patients that are deeply sedated, their hospital length of stay is increased by 1.5 times. Patients that are deeply sedated, no surprise, stay on the ventilator, then it's 3.5 times longer than the person that's lightly sedated. That's forever, 3.5 times. The agents may matter, so if you use benzodiazepines, that increases your ICU length of stay by a half a day, and that may not seem like much, but you add a half a day to the ICU for every patient that we have, and it starts adding up. When they compared agents, looking between propofol and benzodiazepines, benzos, propofol was associated with a lower time on the ventilator, and then Precedex, dexmedetomidine, is associated with a huge jump in getting off the ventilator. Almost 2 days earlier, patients will come off the ventilator if you use Precedex over benzos. Of course, we need to assess our patients. We've talked about the assessment for both pain and sedation. Well, pain, I'm going to talk about sedation now. Patients have to have an individualized levels of what their goal is, right? Some of our patients do need to be deeply sedated because they have stuff going on that you don't want them moving around for, right? Those things, those stuffs going on are not as many as we think. We used to think that patients that were on ECMO had to be sedated, paralyzed, don't move until we get you off ECMO. I don't want you to move an inch. I don't want you to cough, actually. I don't want you to do anything. We actually know now, and Dylan will tell you, those patients are often awake-ish, right? They're in that sort of light area of sedation where they may be able to interact a little bit, answer some questions, move around a little bit. We don't want them pulling at things, right? We don't want them to pull out a cannula and like blood spray everywhere, because that can happen. Dylan's like, oh, traumatic. But the same thing for patients that have had surgery and things like that. So we may have these preconceptions of, I want my patient to be deeply sedated and not experience any of this, but there are actually far fewer indications to keep your patients deeply sedated, and it does harm to them. There are validated tools both in adults and in pediatrics. Both the RASS and the Comfort B have been validated in ventilated patients and non-ventilated patients. So those are easy ones that we can use for all comers, whether you're on the vent or not, to assess pain. And again, with sedation. Again, with sedation, they want you to assess frequently every 4 hours and then an hour after any intervention has been given. We've already sort of talked about this, but the PADIS guidelines from an interventional standpoint say use light sedation over deep sedation, use propofol or Precedex over benzos, and for those patients that have had cardiac surgery, actually specifically the guidelines state that we should use propofol over benzos as well. And dexmedetomidine hasn't been as well studied in the cardiac population, but we use it extensively. Realize that some of the medications that we use do have side effects, right? So, and some of them may not be eliminated very well. So benzos go through the liver, they're metabolized by the liver. Many of them have active metabolites that have to be cleared by the kidneys. Hopefully that's right, pharmacy colleagues. Yeah, Kelsey, okay, good. And so if you have liver failure or renal failure, those things are not gonna clear very quickly. And so how many of our patients have problems with their liver, ischemic hepatitis, or they have renal failure? A lot of them, right? And it's not like CRT is going to clean all that stuff out. So age, everything slows down when we age, right? Our walking slows down, our metabolism slows down, our thinking slows down, but things slow down when you age, and that includes drug metabolism as well. the longer you use a medication with a continuous infusion, the longer it takes to wear off. And so pharmacy has these things, they talk about steady state and all that stuff. When you reach steady state, if you take the drip off, we'll go down faster, right? Completely off. If you reach steady state and we like go down by one, that rate of decline is much slower. So it's going to take a lot longer time to come off of a drip if we're weaning the drip as opposed to turning it off, waiting for it to get out of the system. That may be tomorrow for some of our patients. That may be 4 days from now for some of our patients. I've had some of our patients that have been sedated with drips that take a week to wake up. It's crazy because their metabolism is so slow. And then we order all these things, MRIs and head CTs and EEGs, and like, I guess it's just, I LP people sometimes, like it's crazy. So avoiding drips is possible. For propofol, recognize that you can get propofol infusion syndrome, so PRIS, it's metabolic acidosis, hepatitis, and something else. Triglycerides, yeah, duh, that's why we watch triglycerides. And then propylene glycol toxicity happens with lorazepam as well, and it can happen with relatively low doses. So 1 milligram per kilo per day of use can actually induce propylene glycol toxicity. All right, I'm okay, right? I'm seeing people show up and I'm making sure that I'm not like way out of time. We're good. Okay, so D is for assessing, preventing, and managing delirium. So delirium is a disturbance of consciousness with a reduced ability to focus, sustain, or shift attention. And there are lots of different types of delirium. There's hyperactive. How many of you have seen hyperactive delirium? Every single one of you, right? Because they're crazy. And you're putting them down, and then from then on, they're in hypoactive delirium. Because once they're up, we don't let them come up again. We keep them down, right? Then they actually have delirium. It's just harder to assess those patients. We don't know as well. But if they have inattentiveness, an inability to shift their focus, they're delirious. And then there's a mixed type where they can go back and forth, and we certainly have those patients as well that go between hyperactive and hypoactive and hyperactive. And you're like, I don't know what to do with this person, they're all over the place. Well, yeah, just do the best you can, right? 70% of patients that are on the ventilator, 50 to 70, can have delirium. That's a huge number. It's like everybody, right? 40% of less severe patients, so patients that are not on the ventilator, can have delirium as well. So it's pretty prevalent in our ICUs. It increased costs to our patients by $14,000 per hospital stay. Not insignificant. Mortality, if you have delirium, is 3 times the patients that don't have delirium. That's a big deal. And there are long-term consequences as well. 75% of patients 12 months, so a whole freaking year, after their ICU stay, have some amount of cognitive impairment. 25% of those patients after an ICU stay, their cognitive impairment is so bad, they score the same as patients that have dementia. That's a huge deal. A year after their ICU stay. And we don't see any of that. We're like, yes, we saved a life, right? But they're at home, they can't remember anything, they can't do anything. Physically, they're still trying to recover. And so all of those things start to affect them emotionally. So it's really hard. So the PADIS guidelines say, assess your risk of delirium, right? There are some modifiable risk factors, but actually there are only 2 things in the literature that are independently associated with delirium. One of them is benzodiazepine use. It's any use, and it's also a dose effect. And then blood transfusions actually increase delirium as well. And so when Dylan's asking me for a blood transfusion in the middle of the night because my hemoglobin's 8, recognize that we're not just trying to get our hemoglobin up, we're also trying to prevent delirium. So there is a balance. Everything comes with a risk-benefit decision. Me walking across here and going back and forth has a risk too. I'm probably going to twist my ankle and look stupid. So non-modifiable risk factors. People are as old as what they are, right? I can't affect that at all. They may have underlying dementia. They may have had a history of a coma and they're at high risk because this has happened to them before. They may have had, Brandon may have had to take him to emergency surgery, and those patients have a risk, and he can't help that, I don't think. And so those patients have an increased risk of delirium as well. They may be on previous psychoactive meds. They may have underlying neurologic disorders, and they may have issues with sleep. And I would argue that sleep is probably a modifiable risk factor within the hospital, but right now we don't have a ton of data on sleep. I think it'll probably be a modifiable risk factor that's independently associated with delirium as well. There's more and more evidence that's starting to show that. Got to assess your patient, right? So we have different tools for adults and pediatrics. We have the CAMICU. You guys are all familiar with that, hopefully. And then there's another one called the Intensive Care Delirium Screening Checklist. And it doesn't roll off the tongue like CAMICU. ICDSC. I don't know. We use CAMICU. Pediatric patients also have validated tools. There's a Cornell assessment of pediatric delirium. And then they have a pediatric CAMICU and also a preschool CAMICU. So we have different ones for different ages. They don't know how to spell things. They may not know that a stone doesn't float on water. So it has to be adjusted for the pediatric population. The mantra with delirium is stop, think, and then lastly medicate. So stop is stopping those medicines that we know cause delirium. So reducing deliriogenic, I guess that's a word that I didn't just make up. I saw it written somewhere. Deliriogenic, it's a mouthful, drugs, and those are benzos, of course. We've talked about those already. Anticholinergics, H2 blockers, so Zantac. Ambien and Lunesta are non-benzodiazepine benzoreceptor antagonists. I don't know. They have a benzo-like effect, right? We know that's why we use Ambien, but they actually can cause delirium in the hospital. Goal-directed minimal sedation, so decreasing the sedation, and also doing those daily awakening trials that we talked about. And then removing any invasive devices that they may have also reduces delirium. Think. So think is a mnemonic that helps you think of all the reasons why they may have delirium. You want to rule out those secondary causes. So maybe it's a toxic situation that applies to, are they, what's their glucose? What are their electrolytes? Is their sodium 92? Is it 110? All of those may affect delirium. Are they hypoxic? That can make people delirious. Do they have an infection or have they been immobile for a long time? Those create more delirium. Non-pharmacological treatment, are we using a lot of restraints and tying them to beds? Because if you were a 30-some-year-old man that woke up and found themselves attached to a bed, you may look like you have delirium by trying to wildly get out of bed. Some of our old meemaws do too, right? All of our patients might. If you found yourself to bed, you may look like you're delirious and get treated as well. And then the K stands for electrolytes, making sure all of your electrolytes, potassium electrolytes. You got to get creative with mnemonics. So non-pharmacologic strategies. So optimizing mobility. We have a lecture just on mobility here in a little bit, which is great. Promoting sleep and day-night cycles. And so that's trying to cluster our patient care activities so your patients can actually sleep a little bit at night. Waking them up during the day. Exposure to sunlight. We have windows in all of our rooms. Some of them are brighter than others. I'm thinking about the MICU and at Memorial. They're windows, I guess, by the technical sense, but turning the lights on during the day helps reorient them, right? If you keep the lights on all day, all night, because we don't want to interrupt the patient. They're okay. Shh, they're asleep. Don't interrupt them. Okay, but it's like 2 o'clock in the afternoon, and like even my teenager would be up by then, right? So making sure that they continue that normal day-night wake cycle improves delirium. Regular reorientation, you're in the hospital, it's May 9th, maybe, Thursday. Here's your family's there, you recognize them, and so reorienting them and having family engagement, it's huge for delirium. And then, if you can't see and you can't hear, that's a problem. So making sure patients have their glasses and their hearing aids are also interventions that help delirium, because I'll tell you, there's not a whole lot of medications that actually work. We like to use Haldol and Precedex and give me some Versed or things like that. There are no drugs that are recommended actually to prevent or treat delirium. And so the only caveat is that if you have a patient that is on the ventilator and agitated, and that agitation is preventing them from getting off of the ventilator, they do recommend to use dexmedetomidine, so Precedex. That's the only medicine that has any literature behind it that says that it actually does help. All the other ones don't really help. It may help us. We may see the patient get sleepy for a little bit, but they don't do anything for prevention or treatment of delirium, actually. So really, we're trying to make sure that the patient is safe when we use them. It's not really to treat delirium. And then optimizing pain control. We talked about pain increasing delirium before, and so making sure that your patient's not delirious because they're in a lot of pain, that's number one. Make sure that they're not in a lot of pain. So the other thing I'll say about medications is oftentimes, and I'm guilty of this too, we start scheduling antipsychotics, right? Let's give them a little bit of Seroquel tonight. Maybe they'll sleep. It'll be great. Research shows that those patients don't ever get off of those antipsychotics. They didn't come in on them. At least a third of patients, those are continued as an outpatient. And then they go back to their PCP and they're like, oh, what's this for? I don't know. They started me on the hospital. And it just gets continued. That's crazy, right? So if we have to use a medication, whether it's Haldol or Seroquel or Zyprexa or whatever we're using, make sure we're just given one-time doses, because we're real good about having the habit of not stopping medicines. And that's not just true of antipsychotics, it's true of PPIs and H2 blockers, and antibiotics sometimes we're on for indefinitely, but hopefully my pharmacy friends bop me over the head and make me stop those at least. And so being on an antipsychotic after an ICU stay is really huge for patients that have delirium. Most of them actually stay on it. E is for early mobility. So let's move them up and get them out. So there is delirium is associated with long-term survival, functional status, and quality of life. Delirium, so if you have early mobilization for your patient, it actually reduces delirium by 47%, and the duration by 2 days, which is a long time actually. It increases ventilator-free days by 2.4 days. It reduces ICU and hospital length of stay by 1.4 and 3.3 days, respectively. 50% of our patients in the ICU have ICU-acquired weakness. And so by doing early mobility, it improves muscle strength. There's some scale that I don't remember the name of, but it's a 60-point scale, and when we start early mobility, even if it's just passive range of motion, that scale gets better by more than 10%, just by starting mobility while they're in the ICU, while you think, oh, well, they're sedated, they can't do anything anyway, right? At least doing passive range of motion and all the things that come after that really do improve, and that makes patients more independent of discharge. So their independence, are they able to function without a lot of help, goes up by 70%. And that's big for length of stay as well. We're on the floor, we're waiting for sniffs and authorizations, and do they have a bed, and oh, she had a bed, but then she lost her bed, and then it takes forever, right? So just by mobilizing the patient early, we can get our patients home where they belong with their families. We're often worried about consequences, like what if something bad happens, right? That's what we're worried about. We're worried about patients self-extubating. We're worried about lines coming out. We're worried about patients falling and breaking a hip. All of those are real fears, but again, the literature shows that those don't happen very often. There's one study that's quoted a lot, and there are lots of other studies that show low incidence, but they had 15 serious adverse events out of more than 12,000 sessions of mobility and physical therapy. That's less than 0.1% of patients that actually had anything. A serious adverse event was defined as a change in their physiologic status requiring some intervention. And so they had 3 desaturations, 4 unplanned extubations, 1 fall, 1 Achilles tendon rupture. That's bizarre. 1 person that passed out and 1 person that had a hypertensive issue. That's 15 people out of 12,000 things, 12,000 times that they tried to mobilize patients. I think the risk is worth the benefit for sure. Just with everything, we need to assess our patients, right? Mobility is going to be an individualized goal, just like sedation and other things. We're going to assess what their strength is and tailor their mobility regimen to them. And hopefully that shows up there. I didn't realize that yellow is sort of, anyway. Can you see that yellow, hopefully? Anyway, strength, maybe it's just passive stretching that you need to do with your patient because they really cannot, whether they're awake and have horrible post-ICU weakness and can't do anything, or they're sedated. Maybe just passive stretching is what their level is today. Or it could be active walking, right? We're going to learn how to mobilize our patients that have devices that sometimes scare us. Mobilize patients with Impellas and ECMO and CRT and patients that are on the ventilator. We can do all those things effectively. I know it scares us, but that's why we're going to practice today. Some of the ways that we need to tailor our patients is really based on their body and their physiology. So, what's going on with their heart? What's going on with their lungs? Are they in there? Can they participate? So some of it will be individualized based on that, but it doesn't mean that we don't do mobility. It just alters the plan. Aspects of their care that may alter what we do. Do they have a lot of accessories? Maybe it means that we can't walk a lap around the unit. Maybe we can just stand up beside the bed and march in place, and that's okay. I can't take all of this stuff with me. I can't take the ECMO machine, although we can take ECMO patients and we can walk them. So there's really not a lot of things that are limitations once you start to practice and once you get the logistics down. You got to know where to put your vent. You got to know where to put your IV pole. You got to know, let's have a chair behind them and things. You got to be prepared. Another barrier is going to be staff, right? You need to have some people. It can't just be you and the patient walking down with an Impella and a ventilator and a pump and a chair in the back. I don't even know how you do that. So you need more than one person. You probably need 3 people. We'll find out how many that is this afternoon. And then another barrier is going to be pain and sedation. So again, walking's going to hurt. Some of you are going to have my left hip's going to hurt when I start sitting down for a while, right? Once I stand up, my left hip's going to hurt. It just hurts all the time. And so pre-medicating patients for things like this is smart, right? We know it's going to cause them pain. Assume it's going to cause pain, pre-medicate so that we can walk. It's also going to take more respiratory effort, right? Moving around is going to increase blood flow. It's going to increase our minute ventilation. And so you have to make adjustments, whether it's on ECMO or on the ventilator or with supplemental oxygen to compensate for that. So the patient doesn't start to, get really short of breath because they don't have enough oxygen because they're breathing harder. So we have to predict that. We know it's going to happen. So take care of it ahead of time. Taking steps in mobility, we talked about this a little bit. It is a progressive thing. So first start bed exercises, then dangle on the side of the bed, then maybe stand in place, and then maybe do some walking, whether it's baby steps or whether it's longer strides. the ICU mobility session, you need to assess what equipment you need. Is it available? Is there a ventilator that we can take with us? Is there not? Is the pump going to fail when I walk my patient and beep all over the place and turn off, because that might be bad. So preparing is part of this process. Assessing sedation, managing pain, we talked about that. Optimizing work of breathing, we talked about that as well. The thing that they really stress in the guideline is don't delay mobility because you may extubate later today. Because what are the chances that we've put a patient on a spontaneous breathing trial and we're going to extubate? I mean, it's not zero, right? We extubate people, but it's not 100% either. And also, that may be several hours from now. That doesn't mean that you can't do mobility for a 10-minute session now. And by doing it now, you'll get that session in, you'll get them exercised so that they are stronger when they extubate, and you can do it again once they've extubated. So don't delay just because, oh, we're going to extubate today. I'm just going to do it after they extubate. Well, 2 o'clock turns into 3 o'clock. Hey, doc, can we get out this tube? I told you it takes me forever to do stuff, right? So 2 o'clock turns into 3 o'clock. They're finally extubated. It takes a little bit to get settled and to make sure that we're going to do okay extubated. Then it's shift change, and then we're not going to do it. So do it early. Don't delay it because we're going to extubate later on today. And don't delay it if patients have a little bit of agitation that could be managed appropriately. Maybe we just need to treat their pain. Again, pre-medicate with pain medicines if you suspect that's going to happen, because it probably is. And if it can be managed safely, then still you should do mobility. It may alter the plan of what you're going to do. You may not take a complete lap around the unit or two if your patient's a little bit more agitated, but it doesn't mean that you can't maybe stand in place and march in place in the room, right? Do something is the point. For those that are doing mobility stations, I hope everybody's doing at least one mobility station. The station facilitators will have this. These are from critical care medicine guidelines for mobility about when is it time to start a mobility, what is safe. And we have a lot of these things built into our mobility protocols now. And when should we stop, right? Some of our patients, we know they're going to get a little bit hypoxic when we walk. Prevent that. Turn their oxygen up before we walk, right? Maybe it's not too bad and we can, we've gone up on their FiO2, they still get a little bit hypoxic, but it's 88. Just turn their oxygen up a little bit more so that they can tolerate the mobility session. The exercise is really important. Do it, right? But these are all the reasons why you may not want to continue. A lot of our patients have chest tubes. When they stand, things shift around and then they dump. Dumping is okay if it's just that one little dump. Ongoing bleeding, not, right? 100 an hour, 200 an hour. Oh my gosh, now we have 300 an hour. Where are you, Dr. Ritchie? Somebody come help me. All right, F, we are finally at the F. F is for family engagement. So, raise of hands. Who here thinks that the best part of COVID was taking care of patients without families in the room and dealing with them? You don't have stinky Uncle Harry in the corner, right? You don't have nosy Aunt Nellie that's recording what you say and writing everything down and then asking again. How do you spell that doctor's name? You don't have combative, crazy boyfriends in the room. I know early on it was take that stress off at least, right? Now, who here in the room would choose to have patient not be in the hospital with them if they were in the hospital? Who'd be like, I'll be all right. I'm just in the hospital. I'm sick as crap. I'm probably not going to live. You don't need to come visit. Everybody would want their family there, right? They would want them there as much as possible. And so oftentimes, we think about how easy it is. It's actually not easier to have the family around. You have to call them. You have to call Aunt Sally, Uncle Joe. You have to call Sister Sue. You have to call their husband. You have to call their boyfriend. Yes, they have both. You have to call their kids that are living somewhere else, and it doesn't actually take less time when the patients families are in the room. Probably should go to this next thing. Family-centered care is an approach to health care that's respectful of and responsive to individual families' needs and values. And it really shifts the model to one that's of collaboration and partnership with the family, sharing information and having positive support for that family member that is in the ICU just as much as the patient is. Families report almost half of them have anxiety after an ICU stay for their family member being in the ICU. 12% of them have post-intensive care syndrome. It's a form of post-intensive care syndrome where they have a lot of anxiety and depression and PTSD symptoms because their family member was in the ICU, and that's not even the patient, right? That's exacerbated by not knowing what's going on and not understanding what's going on. Having patients' families in the hospital and having engagement with them reduces ICU length of stay by 1.2 days. How is that? I thought they were in the room, like in my way, getting in the way. I can't do the things that I need to do because the family's there. It reduces ICU length of stay. And it reduces hospital length of stay by almost 4 days. That's a lot. That's huge. That means I can go home on Monday instead of Friday. That's wonderful. So recognize that you're treating more than just the patient that's in front of you. You're treating their family too. And that may just be one person. That may be 6 other people that are in their family. That may be even more than that. Communication helps a ton. So having flexible visitation, open visitation policy, and even allowing virtual visits helps a ton. Having that family member be able to engage with you and the staff and the physician and the patient takes off some of that anxiety and the post-ICU syndrome symptoms that they have. Having daily meetings improves communication so that they know what the plan is and they're not sort of dumbfounded when we call them and we're like, yeah, they're not doing well. They're probably going to die today. They know what's going on with their family when they're there. Engaging them and having them actually involved in multidisciplinary rounds is huge. So we'll talk about it here in a second. I think, when we talk about this, the pediatric side of things, is anybody here from peds? Oh, we got one soul, yes. So the pediatric ICU has been doing this way better for decades, right? Families have to be engaged because that's my baby, right? They need to make decisions. Their consent relies on the family being there and being able to have a discussion. They started engaging families and actually involving them in rounds with the team long ago, and they found that communication is better. Families are happier with their care. They understand the care plan better. They have trust in the care team plan and the members of the team as well, far better if you engage them. And it does not increase the time spent with patients. You can just think, oh, I'm going to be in there forever. It's going to take me forever now because I got to explain everything to mom and whatever. But it actually takes less time because you don't have to circle back around and try to call them again. And it's never really, the message is never very, it's not communicated as much as what the family can see there. They will never truly understand if they're on the phone versus here in person. Participation. SCCM advocates for diaries, getting it out, telling how you feel, how is this ICU care and how is this visit affecting you emotionally, for both families and for patients. You can have families participate in care. There's no reason why they can't brush hair and brush teeth and do some range of motion, right? As long as you teach them the ways that it needs to be done to be safe. There's lots of things that they can help with. And then they are another person, a support staff, when you mobilize a patient. So you don't need the whole unit to come help. You've got a family member, super mom. Supporting the family, so giving them information so that they can navigate some of the words that we say. Sometimes we use big words and we don't even realize it, right? Having some support there with terminology and booklets and things to really explain what's going to happen during their ICU stay and explain some of those terms. And identifying and supporting family needs. Maybe they came from 3 hours away. A lot of our patients do. It's hard for them to come 3 hours away. And that is a stressor that they have that's going to increase their anxiety, increase post-ICU syndrome. And so being able to support that with, like maybe we can get them a room at the hospitality house. Maybe we can get them a meal or apple or something. Having a place in the room for families is huge in this as well. It's a spectrum of engagement. So the most passive form of family engagement is just having them sort of present. Sort of a medium level is making sure they're involved in communication. And then the most active is contributing to care. Are you sure we want to have families engaged and like here all the time? I don't know. Data shows that they have more complete information sharing. They know more about what's going on in their patient, and they understand it better. That's somewhere there too. It actually shows that it's a more efficient use of your time and our time as a team. Patients' families are happier. Patients themselves are happier. And we all care about our satisfaction scores, right? There's more confidence in the team because we're actively communicating what the plan is every day, and we're showing them that we're thinking about all these things. They have better confidence in what we do. What happened during COVID when families were not allowed in the room? It became super suspicious, right? I'm suspicious. I don't know what you're doing in there, but I know it's not right. Because they weren't around. They didn't know what was going on. Yeah, right? Ramona's like, I have more than one of those. And having family engagement may actually prevent adverse event. There's a growing body of literature that shows that it reduces adverse events as well. I think one of our concerns is this stress, the stress on the family and on their comprehension. Are they really going to understand what I'm talking about, right? So we think that there's going to be a fair amount of stress. That's the red and the blue. Maybe no effect, but some amount of stress. Research shows that there's hardly any. Their levels of stress are actually better. That's the green line. We think that they're probably not going to understand. It's just going to lead to confusion. At least 35% or so, it's not going to help, and they're going to be more confused. There's no confusion, right? 96% understand better. So patients understand. It doesn't stress them out. Having them there is helpful. SCCM has a ton of tools, again, to help identify your gaps as an institution and figure out and prioritize which ones should we be doing and which ones are sort of low-hanging fruit, so to speak. Which ones are low resource intensive, which ones maybe high resource intensive but are super important to do. So they actually have tools to help figure that out. This is something I found out, which is really awesome. I didn't know that they had this, but SCCM has an app to help with patient communication. So the patient can now actually communicate with this app, but it also has information on just common ICU things, so to help improve and translate some of the things that we're doing to the patients. Has diaries that they can actually access, and it's a free download on the App Store or Google Play today. All right, let's build something with these blocks. The benefits of the ABCDEF bundle, so many letters. Reduces variation, standardizes process. Every component is synergistic together to improve outcomes. It increases the number of lives saved. That's what we all care about. How many lives did we save this year? It reduces in-hospital death within 7 days by 68%. That's crazy. No medicine that we give reduces mortality by 68%. Decreases mechanical ventilation by next day mechanical ventilation by 72%, reduces delirium and coma by 25 to 50%, reduces physical restraint use, that's important, right, by 60%. That's crazy. That's insane. Why wouldn't we do this? Reduces discharge in nursing rehabilitation facilities, so patients getting discharged to SNFs by 40%, and it cuts ICU readmissions in half. Seems like a no-brainer. Let's use our ABCs. It is a dose effect. The more you use it, the better responses are and the better outcomes are. The inflection is once you get to 60% compliance, that's when you really start hitting a lot of benefit. Restraint use is variable, but restraints are at least down by 15%, up to 60%. Healthcare associated pressure injuries or pressure ulcers decreased by 40%. ICU cost 25% cheaper. Hospital costs down. Mobility increase. Shorter length of stay and shorter mechanical ventilation. I think I'm running out of time. Cost. Is it going to break the bank to do all these things? Sound super resource intensive, right? It's going to cost a ton of money that we don't have, right? We're all asking people about how we can save. This is one study that looked at cost about just figuring out the ventilator days, ICU length of stay, and stuff that was saved. They looked at pre-bundle versus post-bundle, and just to make sure that patients weren't, magically better in one period versus the others, they looked at Apache 4 score. We have all kinds of Apache scores, but Apache 4 score, an Apache 4 score of greater than 65 has a 70% risk of mortality in the hospital. So these are sick patients, and the post-bundle actually was sicker than the pre-bundle. So they had better outcomes with sicker patients, and self-extubation actually happened half the amount that it did pre-bundle. It saved $1.6 million, and this was in just a 24-bed ICU. We have 110 ICU beds within our facility, within the CAMC proper, I guess we'll say. I don't know what I'm supposed to say with that. That's like Vandalia. It's not Greenbrier. I think they have 20, does anybody know, 24 beds maybe in Greenbrier. Greenbrier's on here somewhere in the virtual world. And so that's a lot of ICU beds. So think about how much money we would save if we did this for all 110 of our beds, and that was just 24 beds ICU. So be the change that you want to see in the world, right? Create the climate for change, create urgency, develop a vision and a strategy, engage and empower the organization, so make sure that you're getting all of the stakeholders, communicate what you want to do, empower the vision, be passionate about what you do, create short-term wins, because those early wins are super important to continue and sustain engagement. SCCM, again, has a lot of tools. This is the minimum amount of data that they feel like is necessary. We do a lot of this already, right? We're assessing pain. We're assessing if we're doing SATs and SBTs. We're trying to work on some of our documentation. We do it. Documentation is like, where do I click here? Sedation, analgesia, we're working on this. Delirium, mobility, and exercise is something that we're working on now too, right? And then family engagement and empowerment hopefully is something that we start working on in the future. Believe it or not, Cerner has some helpful tools. So EHR integration of the bundle into Cerner or any EHR actually triples bundle compliance. And these are all the tools that Cerner has. We have several of these. I don't honestly know if we have the last one, this ICU Liberation Operational Unified Analytics Report. I'm not sure. That would be sort of like a higher up thing. But we have a lot of these things actually that we're trying to continue to tweak to make them better. This is what the critical care work list looks like that we do have access to in the ICUs. It tells us, you can't see this, and these are not real people, this is on a webinar, but it tells us how long have they been there, what was our pain, did we do an SAT, did we do an SBT, did we fail, what did we fail, what are our ventilator settings, did we do mobility, and lots of other information. So in a snapshot, you have all that information. This is that analytics tool. with a dashboard that tells you about sort of a global perspective of how many things we're doing. This is bundle compliance in that tool. Realize that the enemy of good is perfect. It can't be perfect initially. Pick something, do a gap analysis. What's the low-hanging fruit? There's a logical progression, right? You can't work on SBT until you work on SAT. And they're synergistic, and you're going to do them together, but can't work on mobility without SAT either. Take the easy wins and start building from there. Sustainability is huge because if you lose sustainability on a project, not only are you wasting resources, but then you lose the people and you lose that excitement about the project, and then they're not going to want to do the next thing that you want to do too to improve patient outcomes. So there are actually sustainability assessment tools out there for people that like tools. This is the clinical sustainability assessment tool. It's very self-descriptive. And so it helps you work out, is this a sustainable plan or does it need to be adjusted? So, went 2 minutes over. The guidelines, the PAD guidelines, are now the PADIS guidelines because we added immobility and sleep. The ABCDEF bundle is like an embodiment of those guidelines to help us implement them. And there's a dose effect for the bundle outcomes. Implementing the bundle improves hospital outcomes. We talked about mortality, length of stay, vent days, all the things. It decreases tracheostomies, and it decreases healthcare associated conditions as well. It improves long-term outcomes. We talked about cognition, we talked about physical mobility and discharge status, and improves satisfaction, right? That's all I got. Thank you. Who's going first? Is it Brandon? Yeah. Okay. We're actually not breaking, but they've been here for a minute, so.
I'm back here and I didn't know it.
No, he was doing something. Hey.
Hey, nice job.
Oh, talk forever. Here. He's not going to hug me. Yeah.
Ready? Yeah.
Thank you. This works just like you would think it would. Okay, guys, we have a break after mobility. I know I talked forever. I'm sorry. Everybody's got to pee. It's like they had too much coffee and juice and stuff. So the next session we're going to do is mobility in the ICU. Does anybody have any questions? I'm sorry, I forgot to ask. We'll have time for questions too after mobility, but what's up, Carolyn?
Have we ever thought about, for day-night orientation, looking at AM and PM clocks, like putting a clock that says it's 5 o'clock AM, or it's...
Like a digital clock that has AM and PM and not the things that you got to like...
And people don't see them, and they don't know it's 5 o'clock if it's AM or PM. That's one of the questions.
That's a great idea.
I didn't hear you.
The Alexis, yeah. Can you set it through the Alexis?
Can you set it through Alexis? Alexis, what's the time? I don't know. Does anybody know the answer to that question? I don't know. I know some of the units actually have a digital clock. I don't know that they have AM and PM on them, though. Most of them have the old school clocks that are like, nobody's going to know how to read pretty soon because nobody knows. So.
My other question would be related to, what is, from a physician standpoint, what is your, oh, that's like really my face.
Sorry.
what is your expectation of when morning starts? I mean, we're seeing in the ICU,
7:01, Carolyn.
then why do we get people up at 4 o'clock in the morning? If we expect them to sleep all night, we're getting people up at 4 and 5 o'clock in the morning. And the night shift nurses are telling us,
That might be a Dr. Ritchie
the
question.
night shift nurses are saying, well, the doctors,
Why aren't they in a chair?
why, they're making us get them up, and so they're getting people up at 4 o'clock. And I don't get up at 4 o'clock in the morning.
4's a bit early. I know that in Open Heart, I got up at 4:30 this morning. In Open Heart, actually, I didn't get to sleep until 3. So, but in Open Heart, I know we changed the timing of our chest X-rays to be later. They used to be everywhere in the hospital. They used to be somewhere between 2 and 4 a.m. And now, like, I'm rounding at 6, and I don't have a chest X-ray yet because chest X-ray people haven't been there, which is good for the patient, but bad for me. It's inconvenient. It's not for me. And so I know that we changed some of the timing, but I think that's a good point. Why do we get labs at 2 in the morning? Why do we do all these things to patients that disrupt their sleep? Great question. No answers. All right, I'm going to introduce Brandon Radow. Brandon completed general surgery residency at CAMC and fellowships in surgical critical care and acute care surgery in Las Vegas. You definitely did those fellowships?
I did those fellowships.
Okay.
Had a good time.
You went to like the hospital and stuff?
Very educational.
Okay, good. He takes pride in treating patients in his hometown here in Charleston, where he now practices surgical critical care and acute care surgery at CAMC, splitting time really between all the campuses at Memorial General and Women's and Children's. Dr. Radow will be talking to us about mobility from the surgical perspective. So welcome, Dr. Radow.
All right, thank you. Thank you, Dr. Ely. Thank you for the introduction, and thank you to the program staff for including me. I think it is. Are you guys able to hear me? I'm a little soft-spoken, so I'll try my best. So I'm Brandon Radow. I'm an acute care surgeon, which means I practice trauma surgery, emergency general surgery, and surgical critical care. I'm going to spend the next few minutes talking about a really important topic, which is the patients I take care of. We're going to talk about surgical patients and trauma patients and the importance of mobility when it comes to these patients. And I'm very happy to see people from multiple disciplines here participating in this, because my patients are all multidisciplinary. And as trauma patients and surgical patients get sicker, we get more and more different teams involved, more and more different specialists. And I think sometimes mobility can suffer. There are questions about what's going on with the patient condition changes, and that leads to really sometimes mobilization being neglected. And that's something I'd like to address this morning. So I want to go over some of the benefits of early mobilization as it pertains to surgical and trauma patients. And what we're going to hear is that the benefits of mobility are all in line with the goals of the Alphabet Bundle, that moving patients through the ICU needs to happen purposefully, and it needs to be a team approach. And we're also going to address some of the conditions and barriers and really get at some of the fears that make mobilizing a trauma patient or mobilizing a surgical patient seem like an unsafe maneuver. So the reality is that patients need to move. Patients that are recovering from surgery, patients that are recovering from injuries, these patients need to move, and they benefit from moving. A lot of what we should be doing is trying to restore normalcy, and normalcy includes a normal sleep-wake cycle. It includes some movements, and when patients have suffered some of these injuries, we have to address those injuries, but not forget the whole picture, which is the patient. And these patients are going to need a lot of help. They have lines and tubes and dressings, and they need a lot of help to get back to normalcy. So I wanted to highlight a couple findings from some studies looking specifically at trauma ICU patients. So in some published studies looking specifically at trauma patients, they saw early mobility had decreased ventilator days. There were improvements in ICU mortality, all hospital mortality, and decreased delirium, decreased length of stay, and improved functional ability. So when I see those kind of results, that's the real goal of critical care. That's the real goal of trauma surgery and emergency general surgery, is treating life-threatening problems, and we see that early mobilization can help save a life, and getting people back to normal. And we see that early mobilization is part of that process, and a necessary part of it. But I think, when I picture a lot of our patients, and I'm sure when you picture a lot of our patients, we think of patients like this. This guy has obviously some pretty severe injuries. He has an intracranial pressure monitor. He's intubated in a C-collar. There's a lot of things that would make mobilization for this patient difficult or maybe even contraindicated. And the importance of this conference, the importance of these campaigns moving forward, is trying to address is mobilization safe, and what efforts are we going to need to collaborate to make sure that we can mobilize the patients that need mobilized. In a prospective study, a group implemented an early mobilization plan, and then they recorded all the times that mobilization didn't happen, and described that as some of the barriers. And so, in addition to injuries and devices that may make mobilization difficult, what people reported was the patient conditions, whether patients were off the floor or going for procedures or in anticipation of procedures, and missing orders, which is a lack of communication. So when I look at this list of reasons why a patient may not get the mobility that they need, these are all of the things that go on in our ICU patients all of the time. And so if we look for a reason not to mobilize somebody, we may find one, and that reason may or may not be a valid reason not to mobilize somebody. So I think it's important that we're aware, are we limiting ourselves unnecessarily from mobilizing our patients? The injured ICU patient, our trauma ICU patients, many have extremity fractures where we need to think about their weight-bearing status, and many have spine injuries where they need to maintain spinal precautions or have their surgeries prior to mobilization. So when addressing these kind of patients, we need to have conversations amongst all of the team members, all of the relevant healthcare providers, to assess if a patient is actually cleared for physical therapy. The American College of Surgeons is the largest governing body for trauma surgery and for trauma centers. The Committee on Trauma and TQIPS recently released best practice guidelines talking specifically about spine injury patients, because we know those patients represent a significant portion of our severely injured patients. They're a significant cost to our healthcare system, and some of their outcomes are unfortunately rather poor, meaning there's a great opportunity for improvement. They emphasized mobilization early and tracheostomy early. And when we think about the ICU and ventilator bundles, this is all about progressing patients along quickly. They specifically mentioned mobilization within a week for spinal cord injury patients. And when we think about the time that it takes to normalize hemodynamics, get a patient through surgery, and think about an early tracheostomy, a week can be pretty rapid. But I think that is certainly a goal that we need to pursue. They specifically mentioned to reduce contractures and to prevent decubitus ulcers. But when we think about, just patients' emotional states, their families' concerns while we're planning next steps after the hospital and thinking about rehabilitation, I think the sooner a patient can prove what they're capable of, or in a worse scenario, demonstrate what their needs are, the sooner we can get those plans started, and that's obviously for our patients. So when we do have new trauma patients admitted, we want to make sure that the spine has been cleared before we move patients. So a lot of patients will arrive to ICUs. They may still have a C-collar in place, so their cervical collar is on to keep the C-spine immobilized. But some patients, that's a long-term treatment, and so those patients can still ambulate. They're going to go home with their C-collar. They can still be up and moving around with their C-collar in place. If there's any question about weight-bearing status, particularly in a new fracture that maybe hasn't been treated, or even in a fracture after it's been surgically fixed, we just want to clarify that. And what we find a lot of times is the primary team, the trauma surgery team, may not have the answers, and it's conversations with orthopedics or conversations with some other specialist group. And that's why a lot of multidisciplinary rounds or sort of running of the list from an interdisciplinary level is best to happen in the mornings. When we think about some of the surgical devices that can cause some apprehension or cause some concerns about mobility, we think about vascular lines like central lines, dialysis lines. We think about wound vacs and wound dressing changes that could become dislodged while patients are moving around. We think about braces like C-collars, TLSO, or LSO devices, as well as chest tubes. The overwhelming theme here is that these products and these instruments are all safe during mobilization as long as people are being cautious, as long as patients have adequate help, and we're making concern not to let things get dislodged. And I do have a couple photos of some of these devices coming up. These are all Google images. I didn't violate any HIPAA rules or anything like that. So walking is going to be more difficult. The more lines and tubes patients have, the more of these devices that patients have is going to make walking more difficult, but none of these specifically contraindicate walking. So we should think about mobilizing patients. We should think about moving patients. And as you'll hear from Dr. Ritchie, there's going to be a process where we assess patients and we move them along and progress them as their condition allows. So here's a couple patients walking around with really all the devices. The patient on the left, she's got, it looks like a couple Plurivacs. We see her monitor. She's got a cordis in the neck there. So when we see these devices, we want to be careful of them just as we would when the patient's in the bed, but we want to be willing to help and not so afraid to help. You see only one person here. This probably is going to require more than maybe just one person helping them walk. Here's a couple photos of some of the braces we may see. So these braces are designed to be comfortable long-term solutions for patients. They may immobilize the thoracic or lumbar spine. They may mobilize the cervical spine. And when patients are in these, typically they're not going to have mobility restrictions. They may have other injuries or special conditions that restrict on a nuanced basis. But part of the purpose of these bracings is to allow patients to be able to move. In a study looking specifically at pulmonary artery catheters, there was shown to be no increase of complications. I think it's worth noting that the complications they did see are really the problems you would think from mobilizing a patient with a PA catheter. They saw bleeding around the catheter, dislodgement, and arrhythmias, but they said these occurred at the same rates as when patients are still bedbound with these catheters. We may have other devices like ECMO, endotracheal intubation, or cardiac devices. Patients have been reported ambulating, moving around, sitting at the edge of bed with all of these devices, and reports are coming back of successes and safe implementation walking patients in all these types. I wonder why she didn't get extubated, but let's hope they know to do their awakening trials and their breathing trials. And yeah, she looks quite awake. Must still have a remaining pulmonary problem. But intubated patients can be mobilized. Ambulating intubated patients is certainly a scary thought when it's new or when we haven't done it before. But I think that we can also use this as evidence that if a patient that's intubated can walk, they can certainly sit up to the side of the bed. They can participate in some range of motion exercises, and they can certainly benefit from work on their strength while they remain in bed. And then active physical therapy has been shown to be safe during ECMO. So we would certainly not want any of the tubes to get dislodged. Recanalization could be quite a nightmare. But in the right setting with the right procedures and the right people involved, even walking on ECMO can be safe. So early mobilization is feasible, it's helpful, it just requires a team effort. I appreciate everybody's involvement in taking care of our critical care patients. We're going to hear about some of the changes and plans specifically here for CAMC. I think there's quite good reason for optimism, and I'm excited about where we're headed together. Thank you.
Does anybody have any questions? We're going to probably save questions for the end.
Yeah. Is he expecting it?
I'm going to introduce Dr. Ritchie. Get your slides here. Dr. Ritchie is a graduate of the Brody School of Medicine at East Carolina University. He trained in combined emergency medicine and internal medicine at SUNY Downstate Kings County Hospital in Brooklyn, New York. He later completed fellowship training in critical care medicine back at Brody School of Medicine at ECU. He spent the last 8 years working with cardiac intensive care patients and specializes in right heart failure, cardiogenic shock, mechanical circulatory support, ventricular assist devices, and ECMO. He's board certified in internal medicine, emergency medicine, critical care medicine, neurocritical care, and critical care echo. And ECMO, the AEAC, whatever that one is. Dr. Ritchie will be speaking to us more about mobility from the medical perspective. So, welcome, Dr. Ritchie.
Still no? Okay. All right. So this is all through what we just talked about with the ABCDF bundle and really focusing on the E part of it for early mobility. Again, we're down here in the E section. And so implementing BMAT, and this is bringing mobility to our ICUs. For those that are not familiar, BMAT is Bedside Mobility Assessment Tool. This is actually being rolled out to all the floors, not just the ICU, but it will be used in the ICU. It is a validated assessment and functional mobility screen to determine the patient's level of mobility. So if you think about it, after we do this assessment, you will say they are level 1, 2, 3, 4. So you'll determine what level they are after doing this assessment. And it is a nursing tool that also helps recommend, based on their level, what is safe to do and what things you can use with them when you're doing their mobility. It promotes early mobility. It reduces variation in care because everyone's going to do the same assessment. You're going to identify the equipment needed. So you say, okay, my patient is level 1, my patient's level 2. What does that mean I'm able to use, or what can I have as an adjunct to help them mobilize? It reduces nurse injuries because as you use your adjuncts, you're not sitting there trying to do it all yourself and throw out your back. And it helps decrease falls. And then it also decreases VTEs and pressure injuries, as you would expect, because you're allowing them to mobilize more. And as we've said, it decreases length of stay. There's visual people, not visual people. This is 3 different ways you can look at it. So level 1 that we use is called sit and shake. Level 2 is stretch and point. Level 3 is stand, and level 4 is walk. There's other places that use a similar, that still use the BMAT, and they'll use these pictures. And so the idea is that you have in-bed people, you have edge-of-bed people, you have chair people, and you have walking people. It's kind of how you think about it. Is my patient safe? Oh, they're not safe to get out of bed. They can only do in-bed stuff. My patient can probably sit on the edge of the bed, but they don't have enough strength to actually stand up and do standing exercises. Or my patient can stand and actually can ambulate. So those are kind of the different levels that we're going to be walking. Is going to be level 1, 2, 3, and 4. The BMAT assessment is done at admission, and then it's supposed to be done twice a day because you're mobilizing these people twice a day, is that you're assessing them as you kind of go through it, and then you say, okay, they're still at a level 2, or no, now they're up to a level 3 because we've improved their strength. So you want to do that assessment twice a day, which would be once a shift. And we do that for the entire hospital stay, so not just in the ICU, but it moves on to the floors. It cannot be completed on patients who do not have an activity order or they fail the safety screen. Now, if they do not have an activity order, that's where a lot of it is getting on the phone and being like, hey, this patient doesn't have an activity order. Can you please put an activity order? And then that way you're not just being like, great, I don't have to do this, because our goal is that we want to be able to do this. We want to be able to get these people moving. We're supposed to be having an activity order on everybody whenever they come to the ICU, but obviously sometimes that can get missed. And so you can say, hey, I have your patient. I see all this stuff here. I don't see an activity order. And then the safety screen, which is important for a lot of people, we're using one that's called MOVES, which is another acronym to remember, but it will be implemented within Cerner so you can see it every time as you go over it. M stands for myocardial. So if they have a new MI on their EKG, probably don't get them up and walk them around. That doesn't do as well. If they have a new arrhythmia medication added within 12 hours, so they've gone into AFib or they've had runs of VTAC, that would be a stop for you to at least notify the physician. That doesn't mean don't do it, but it's one of these things that say, hey, they didn't pass the safety assessment. I would need to call my physician and say, are you sure that it's still okay for me to get this person up? I know that they recently were put on amiodarone because they went into AFib, and you can say, yeah, it's fine, but this would be a stop that just says you can't do it independently. This is actually taken away, excuse me, this is actually taken away in open heart recovery unit because we have so many patients that are on antiarrhythmics post-cardiac surgery that middle one is actually not in open heart recovery specifically. New unstable dysrhythmias within the last 12 hours. Again, that would be a stop for an automatic moving forward. You'd have to talk with the provider. O stands for oxygenation. So if they have a sustained desaturation less than 88% or less than whatever the patient's specific goal is, then they would not pass the MOVE safety screen. If they have an increase in ventilator support within the last 4 hours, they would not pass the safety screen. Again, this doesn't mean that they can't do it. It would just mean they don't pass this safety screen, and you would need to speak with a provider. If the current vent settings have an FiO2 greater than 60%, a PEEP greater than 10, or a plateau greater than 30, this would also be an automatic stop and notify the provider. And then oxygenation of 100% if you're on like OptiFlow or on a BiPAP in a non-intubated patient, where they would not be able to pass it. V stands for vasoactive. So if you're having an increase in vasopressor requirements, they would not be able to pass from the MOVE safety screen, and then any new vasoactive medication added. So if you were on Levophed and you added vasopressin within the last 2 hours, then you would have to stop here and speak with the provider. E stands for engage. So any change in neurostatus, any cervical or spinal injury without clearance from neurosurgery, orthopedics, whoever needs to be cleared by it, you would want to make sure that you would stop and then wait for clearance. Excuse me. And then special considerations would be the S. If they have a hemicraniotomy and they don't have a helmet, if they're on neuromuscular blockade, epidurals, special lines, that you would have to consider whenever they have it. And then comfort care. So if they have a comfort care order, you obviously wouldn't want to be doing these things with them. They wouldn't pass. And then if they have a RAS of greater than or equal to 3 and they're very violent, then this would stop on the safety screen. And again, this just means you want to contact their provider and say, look, they didn't pass MOVES. Do you want me to move forward, or do you want me to do anything differently? If they failed the MOVES assessment, then what you do is you do strict bed rest. You would still do your repositioning every 2 hours as you would normally do. You want to do passive range of motion, and I think that's the thing, like Dr. Ely spoke about, was that you get an improvement in your muscle scoring system if you do the passive motion. So just because they can't do anything doesn't mean that while you're assessing them, while you're in the room, while you're doing something, you can't do some quick passive range of motion. Having family in the room and showing them what passive range of motion is means that they're going to get some muscle activity so that they don't get quite as much ICU weakness. Passive range of motion can just be flexion and extension of the elbow and shoulder, about 30 reps per joint in the upper extremities, and the same thing with the knee and hip, 30 reps per joint in the lower extremities. So those are things that can be done in just a couple of minutes, 3 times a day, to be able to improve mobility as they advance. We have the hover mat or the air pal. These are things that will help be able to move these patients because they're on strict bed rest. So if they need to be moved up in the bed or they need to be adjusted, so that way you're not just getting injured, is that we have this ability, especially if the patient is morbidly obese or has something that's going to make it difficult for you to be able to move forward. This can help you be able to get the patient up in the bed or do whatever you need to do safely without injuring yourself. BMAT level 1, so they passed moves. Now you're doing the assessment to see if they're BMAT level 1. This is a test of hemodynamic stability, a test of core strength, and a test of upper extremity strength. And again, this is called sit and shake is what it is. And it's this move right here. So they're going to be, you want to get them to the edge of the bed, and you want to see if they can shake. So specifically, you go from a semi-reclined position and ask the patient to come to a seated position at the edge of the bed. So you ask them to do it. They can use the side rails, but you don't want to physically assist them in this. You want to see them be able to do it, to be able to get to the edge of the bed and be able to sit up without assistance. And then they have to be able to maintain this position for 2 minutes. And again, that's assessing for that hemodynamic stability, that core strength, to make sure that they can stay upright and that they can hemodynamically tolerate sitting upright, like they don't drop their pressure, they don't get tachycardic. And then once they've been sitting for that 2 minutes, you do a handshake and you actually make them cross their midline. So that's going to show strength of their upper extremities, that not only can they lift their hand, but they can cross over to the midline as you shake it. So that's where the sit and shake comes from. If they fail that, they will be designated as a BMAT level 1. If they pass, then you would move on to BMAT level 2 for assessment. If they're BMAT level 1, now this is something that's very interesting, and so these are patients that would not be able to sit up and get to the edge of the bed, right? So if you know somebody, like if they have a CP impella in their groin, you're not going to ask them to go sit up and be on the edge of the bed. So they're automatically going to be at a BMAT level 1. But otherwise, they're super normal. They can move all the other extremities. They just can't move that particular extremity. So there is a certain level of saying, is this person level 1A or level 1B? And level 1A is somebody who just can't do it overall because of their sedated, they're critically ill, there's something that's saying they can't get to that. And in this situation, again, you're just doing your exercises passive range of motion because they're not really participatory. They're in bed and bed bound, but non-participatory. You can still, this person isn't, doesn't mean they have to be on strict bed rest though. So they've passed moves from a safety screen so they can safely be moved. They are just not participatory. So you can do things that go beyond the hover mat, is that you can go to the max sky lift or the maxi move lift where you can actually pick these people up and put them in a chair, or you can have them be sitting up or doing things and have them doing some sort of moving around while you're doing it through there, but you're doing it safely because you're getting them to a chair with a sky lift, you're getting them to a chair with like a maxi move lift. So those are things that we have in the hospital with it. Ideally, you want to use the chair position in bed or sit in chair for meals if they're able to do it. And then you want to use these equipment to safely transfer these people out of bed and again, reposition if they're in bed every 2 hours. Mobility level 1B are people that are bed bound but are able to be participatory. So whenever they have the impella in or something that's keeping them in bed but otherwise are able to move extremities and be able to participate actively in exercise. And so this changes. You want to do active range of motion. So in open heart recovery unit, we actually have these pedal exercisers and we have resistance bands. And so the pedal exercisers, you can actually have them where they can do it with their hands and you can put it on their bedside table and they can do their pedal exercise on their hands. Or if they're able to move their feet but can't get out of bed, you can actually have them do it with their feet in the bed and do it that way. And then we have resistance bands that are designed to attach to the bed so that you can do these active range of motions where they're participating as opposed to passive range of motion. If they pass level 1, you would move on to level 2, and this is called stretch and point. And this looks at lower extremity strength and it looks at stability. And so when the patient is seated, you ask them to stretch their leg, flex their ankle, and point their toes. and you just do it with both legs. This is what it looks like. Lift the leg, point the toe, and then obviously if they have had weakness on one side or amputation, then you just do the one leg. But stretch and point. This again is going to tell what their lower extremity strength is and what their stability is. If they are unable to do that, then they're designated as a BMAT level 2 because they're able to sit on the edge of the bed safely. They just don't have that lower extremity strength to be able to move on to level 3. So if they do pass this, then they would move to a level 3 evaluation. Again, your equipment is going to be a little bit different. So you have your pedal exercise, you have your resistance band, you're working on the edge of the bed. So you're not necessarily standing, but you're working on the edge of the bed. You can still do all these active range of motion exercises. There's also something called a Sarah steady, where they can kind of put their knees on here and lean against it, and they can kind of be moved around without actually using their as much strength in their lower extremities. So they can be safely moved and kind of be able to move to the chair or be able to go to a bedside commode or whatever they need safely without you getting injured as you're moving forward. BMAT level 3 is called stand. So if they pass the first 2 levels, you would go with stand. And this is standing tolerance, balance, and weight bearing ability. You just tell them to stand. Have the patient come to a standing position onto the bed rail. If needed, they can hold on to it, but you don't want to be able to necessarily do it on their own, and you want to be able to see if they can do it for a 5 count. If they fail, then they're determined to be their level 3, and if they pass, you can move on to level 4. So if they fail, you're saying they can stand, they just may not be able to stand up fully, and so you want to start talking about doing kind of marching in place exercises or standing exercises as opposed to going to like full ambulatory. Ideally, if they need support, you can still have your pedal exercise, your resistance bands, whatever you want to do on the edge of the bed, but you can start adding things like a gait belt to be able to kind of support them as they are able to stand for short periods of time or be able to kind of move them, or you can start talking about doing a walker, and that's going to just be able to support them in somebody that can't be supported on their own. So if they can't stand up by themselves, but they can be helped with support, that's how they're able to be a BMAT level 3. And so you can do a walker in the room, you can do your active exercises. You do want to sit on the edge of the bed or in a chair for meals, and then if you're going to transfer, stand, or walk, you want to use one of these devices to be able to help them. And then if they pass level 3, you want to move on to level 4, which is just walking. That's strength and stability and balance. You just want them to ask them to stretch their legs. This one's supposed to be for march in place. If they can march in place, then they would go for ambulatory on there. If they fail, they would go back to a BMAT level 3, and if they pass, then they would be designated level 4. If they're going to be level 4, you would want to still talk about doing active range of motion, walking them around, having their cane, their walker, and then you want to have them walk in the room, walk in the hallway, whatever is as much as tolerated going forward. Ideally, you want to encourage out of bed for all meals, for all ADLs, to just continue that mobility, continue that strength going forward. These are all the devices we have and the different levels that we have them. When to consult physical therapy. So this is very nurse driven. That's what it's designed for. So physical therapy isn't for everybody. But if they have a decline of 1 level from baseline, so you've assessed them and then sometime during their assessment they were a level 2, now they're back to a level 1, or they're a level 3 and back to a level 2, that's when you would want to consult physical therapy. If they have a sudden decline by 2 levels, definitely physical therapy. And then if they have just a gradual decline over 4 scores, you would want to do it as well. So some myths, some things that definitely want to promote mobility is you can walk patients that have pulmonary artery catheters, and Dr. Radow spoke about that as well. You can walk these patients with chest tubes in place. You can get them out of bed or walk while on a ventilator. You can get them out of bed and mobilize, and patients on CRRT to get them to not lose their strength if they're on these things. Additives to aid in mobility. So we have these boards that are on our walls, and they have these things here where you can write what their activity or mobility level is. So after you've done your BMAT assessment, you would say, my patient is a BMAT level 2, or my patient is a BMAT level 3. You can write those things down, and then you can kind of decide up with assist, 1 assist, 2 assist. You can kind of make that assessment that just says, hey, yes, they can get up. They're a BMAT level 3, but they do need some assistance if they're going to be doing any walking or certain helps with things. This could be helpful. You can have this like out of bed plan. You can kind of pick the things that would be moving forward and kind of say, this is what the level is. These are the assist devices we're going to use. Did they get mobilized today? We would love for everyone to get mobilized 2-3 times a day at least. And then any staff needs going forward. Dr. Ely spoke about this, but one of the things that's going to help people get mobilized and not be delirious and moving forward is identifying anything that they would need being able to get up and walk around. It's a lot harder to walk around and feel comfortable if you can't see. So you want to make sure if they have glasses, they're wearing the glasses. This also helps out with delirium. If they have walking aids, if they have orthopedic shoes or prosthetics, tell them to get them from home so that they can feel more comfortable getting up. We'll have patients that have an amputation, and so they're not getting up as much, but as soon as they can get their prosthetic from home, they're able to get up and do the things that they would normally do. All these things definitely help out with delirium too. So getting hearing aids in, getting dentures in, getting all these things that make them feel like they're at their baseline is going to make a huge impact on delirium as well as getting them mobilized. Out of bed mobilizing with a femoral catheter. These are all things that we're trying to do moving forward. Decreasing bed rest times after removal of femoral catheters, so like 2 hours instead of 6 hours, and then walking patients with advanced cardiac devices. This was a study that showed 77 patients with 92 femoral catheters. They had 210 separate physical therapy sessions, 630 mobility activities. They went to the side of the bed, they stood, they transferred, they walked, all of these with femoral catheters in, and they had no bad outcomes. No catheter-related complications. Standing and walking was very feasible and safe with a femoral catheter, and it supported early mobilization. So I know that this is certainly a big change or kind of a comfort level on things, but these are all things that are very comfortable. Central lines in the groin, vas caths in the groin, arterial lines in the groin. All these things can be done where you can actually get them up, get them to a chair, and walk them around safely. Removal of peripheral artery catheters. It's been shown that you can reduce your removal time from 6 hours to 2 hours. So once you remove it, you only have to have 2 hours of bed rest versus the 6 hours. That's going to get people out of bed a lot sooner, and that's going to get people mobilized a lot sooner and help out with mobility, help out with keeping their strength. And so there's a lot of data that says that this is very safe to do with your femoral arterial catheters. Walking with advanced cardiac devices. So I don't have a picture of us at this hospital walking anybody with an intra-aortic balloon pump, but we've been shown that it's been very safe to walk people with a balloon pump. You put them on like a tilt table of some sort of device that's going to allow them to stand up without bending at the hip or bending their leg, and then they're able to walk around safely without any adverse events. This is a patient of ours who had a low EF. They had pretty severe heart failure. They also had pretty severe coronary artery disease, and they went for a CABG, and they were supported with an Impella. So they have a assist device going into their chest right here and into their heart, and because we were able to put it in the neck instead of the groin, after they had their CABG, they got extubated, and this is them on post-op day 1, getting up and walking around. So you have somebody that has an EF of 15-20% at baseline, which before that would not even be a candidate for surgery or would have a very prolonged course after surgery just from a sick heart, is that he is feeling good, walking around, and safely ambulating, and we have 2 people able to do that. Here is an ECMO patient being walked, so it also is very safe to do that as well with the right amount of support. Here is another patient that we have at our unit that was able to be mobilized on a ventilator sitting in a chair, so they're able to keep that core strength, they're able to sit in a chair moving forward. Here's some barriers. So lack of leadership. This is what was identified at Wake Forest, Johns Hopkins, and University of California, San Francisco. And one of the biggest lack of leadership was no interdisciplinary team. What we have is we actually have a mobility steering committee, which we've implemented, and that's how we're bringing forward with BMAT. We have one of their issues was lack of staffing and equipment. We have added a bunch of equipment. We're working on adding staff. We have mobility techs. We have cardiac rehab, and depending on which unit and moving forward, going that way. Lack of knowledge and training. That's a lot of the stuff we're doing here and getting the education out for BMAT. Lack of physician referrals for physical therapy. We have since been talking about how we can make sure we have the activity orders and when it's appropriate to consult physical therapy. Over sedation. This is why we're talking about the whole A, B, C, D, E, F bundle. Delirium. Making sure we're doing our screening, make sure we're minimizing our sedation. Lights on during the day, we turn them on at the beginning of the day, we leave them all on. These are all things that were barriers that we're working towards right now to have delirium algorithms within the ICU to make sure that lights stay on appropriately. And then the safety that we talked about. So again, this is Duke implemented this exact same thing with BMAT and MOVES. They had decreased ventilator days. They had decreased ICU length of stay. For vented patients, for surgical patients, they had decreased ventilator-associated pneumonias. They had decreased pressure ulcers, and they had decreased falls. All of this was per event, how much money they saved. For this 6-month study, they saved $350,000 and $178,000 just on length of stay. In this 6-month study, they saved $620,000. If you double that to extrapolate it out to a year, in this 6-month study, they saved $1.2 million by just implementing their BMAT and MOVE. So getting patients up, moving them around is how we're going to be able to not only make patients do better and do it safely, but it also saves a whole lot of money. All right, any questions?
I have a question. Our hospital policy says that once we remove a balloon pump, which is like a really big hole, right? The patient has to be in the bed for 8 hours, 6 hours. I always tell the nurse 6. I say, change it to 6. Does it matter what size catheter is in an artery when you take it out, when you mobilize, like what, and then after you take it out, does it matter what size it was, like after the hole that's left once you've taken it out?
Yeah, so it absolutely does matter in terms of the hole size. What we're finding out is we can be a lot less conservative. So balloon pumps obviously are a much bigger hole than, and we have sheaths from post-cath, and we have our femoral artery catheters, which are only like 18 gauge, 20 gauge. Those are a lot smaller. So all those can have varying times. With our very small ones, with just a femoral artery catheter, you can really scale back that time to like 2 hours. Whenever you start talking about sheaths, they actually are doing a huge push post-cath where they're reducing the times where it used to be 6-8 hours, where I think it's come down tremendously as well. And then balloon pumps, again, we're showing that they are bigger, so you're not going to do like the 2 hours, but you can probably drop it down to even like 4 hours. But they can still be safely moved. Like I said, they talk about safely moving people with intra-aortic balloon pumps. They talk about safely moving people that have VA ECMO in their groin, or even VV ECMO, for both of those to be able to do it. So right now, our policies have that they have the 8 hours with the balloon pump, 6 hours for femoral sheaths and femoral art lines. But one of the things that's being looked at as we move forward with our BMAT and moving forward with our mobility is reducing those times to increase mobility and earlier mobility.
That sounds like a process.
It is.
What other questions do you have? Dr. Radow's here too, if you guys have any questions from a surgical standpoint. Everybody's cool. They're going to mobilize all their patients with their art lines. I can tell.
I just wanted to know that when you said that y'all were going to increase staff, is there going to be like a BMAT team that comes around to the ICU to help mobilize these patients? Or
So it's something that we're looking into. We've had certain trials to say, hey, can we do this? We've had it in the past. As we look at this right now, we don't have anybody like as a permanent going forward, but it's something looking at having like mobility techs or people that could come around and do it. The whole idea, though, is that this would be nurse driven, and as we get the devices and other things to make it easier, is that you clearly are super busy and have a lot of work, and if it takes 2 or 3 people, that can be somewhat of a daunting task. By getting comfortable with getting family involved and getting the more you do it, the easier it becomes. But it is something that we're looking at is implementing. Is it feasible to have like techs and stuff? But right now it's not going like everywhere. But we have looked at it in certain units.
And I think family engagement's huge. Once your family is there and you sort of set the expectation that we're going to get them up and move them around, they start to become very engaged, and they're like, okay, I'm ready, I'm going to help. What can I help with? Right? And so we'll just put them on CAMC staff, and they can park across the street and walk, and then they can help be part of our mobility team. But engaging families is going to be super helpful, and everything costs money, but we're going to maybe save money in the long term.
Where does the liability fall when the family's involved? And I ask that because previously my dad, a few years back, was in a hospital in South Carolina. And I offered to help pull him up in the bed to reposition and turn. And the nurses said, oh no, we can't let you do that because you're not covered by the liability of the hospital.
Yeah, I can't answer with great certainty, but what my approach would be for that patient's family member is to have them engaged in ways that wouldn't, I wouldn't want them actually pulling up the patient in the bed, right? I wouldn't actually want them underneath the armpit walking down the hallway. Give them tasks that they are not going to be in that situation. I have no idea, honestly, what our legal team, I'm probably holding that too close, what our legal team's answer is on that. But I would have them help some way, even if it's just being your cheerleader. You're doing a great job, be your cheerleader, couple more steps, you can do it, and be that encouragement, I think would be helpful. But I don't know the answer to this. Wes is in line. Hold on, I'll come back.
It's actually piggybacking off a lot of these questions as well. What is the expectation for seeing some of the pictures in mobilizing these patients that have had Impellas, ECMO, ventilators? How much staff was actually utilized in those situations, and what's the expectation for how that will change as you get more comfortable doing that?
It's still going to take a while. At times it's taken 2 or 3 people just to get our post-CABG patients up. Whenever it's been ECMO patients, it's usually 2 physical therapists and 2 nurses and the respiratory. You're talking about 5, 6 people at times. We'll have them duck out during a picture, so it looks nicer.
No, man, it only takes 2.
But it does take a lot initially. I think one of the greatest benefits, though, is just as you start recognizing those walking tools or helpful things, so it makes it. So we have a cardiac walker in our open heart, and we have it. We have a little bicycle basket thing that you put in the front, and we hook our what?
With a bell.
With a bell, yeah. And we hook our chest tube up to them. And then we put our monitor in there, and they're able to sit upright, and it's able to hold a lot of stuff. And so that kind of takes away one, because we have better equipment instead of somebody having to hold the drainage devices with it, is that you're able to just kind of hook it all up there. So that's helped. To be able to just have one less person. And then this device, while we don't often use it, it does have a safety device that allows it so that if they do get tired, they can sit on the device itself instead of having to have the chair be pushed behind them. So again, that's one less person that has to be like just walking a chair around, so that person can be doing something else. So it's more to do with like what we're getting to help you not have to have as much stuff with it.
And I think the first couple of times you get a patient up, you always need more hands because you don't exactly know all the things that you need to maneuver. But once you know what you need, I need the vent on this side, I need my Foley on this side. And once you know all the things that you need to maneuver, you need less and less people. And we do walk our Impella patients with 2 people oftentimes. So
do we have this equipment available now?
the equipment that you
These
saw,
chairs that he's talking about?
that's the Sarah study, right? That you're talking
Yeah,
about?
Sarah study, like even the walker that was shown in the pictures, it looked like it had places where chest tubes.
I don't know, this
could be
doesn't work.
on and everything. It may have been in your slides.
I think it was in Dr. Radow's with the platform on it for chest tubes.
Because sometimes walking these people, you're having them hold onto their pole and you're holding on
Yeah,
to
we-
the bar and everything.
We have this device. This one is ours. It's an open heart that has all the things that can fit in the basket and do all the things with it. So we have those. It's within our company. Like other units can get it. We just put in the ticket for it, and we have the stuff to be able to get it. Everything that's on where is it? These are all things that we have. So this is the actual document from CAMC that says this is what we're providing for the different BMAT levels. So all of these things are absolutely provided. Under walker, we ended up getting a cardiac walker, but I know that there's a variety of them. So it's just a matter of getting them to the units.
The units are in the process of buying them with the mobility steering committee. We're taking up kind of what equipment is needed and what units, and then getting that out to the units. So we're working on getting all this equipment on your guys' unit. Storage is an issue, so we may have to come up with some creative ways for storing some of these things.
We need a mobility shed. Any other questions?
Just a quick question. I probably don't need that. Sorry. Hi, I'm Robin. I'm at Taze now. I used to be up there at Memorial. We have the privilege or the honor to have physical therapy down there with us, but is this going to roll out to them specifically to help us? Because a lot of times they're afraid to even get a patient up with a line in them, even if we're like, no, they can sit on the side of the bed, or we had them up earlier standing, and they'll be like, oh no, we're kind of hands off on that. So my question is this going to roll out to them to say, hey,
or even ambient for like 48 hours?
Yeah.
Right.
So I can tell you that working with the cardiac rehab specialist and the physical therapist in open heart when we've done it is they've become comfortable. Like when they first came in, like, this is what we're doing, they were like, I've never done this before. And then now they do it without any issues. So I think it's a matter of kind of passing that information down, because at Memorial, we absolutely do it. It should be able to be passed down.
Over PT and TASE. Sometimes TASE is a little different, so I don't know. The structure is a bit different.
Set up, we did get physical therapy involved with us. We have our own kind of little, we're doing, like, a few of us are doing the Charleston steering committee, but we've set up like our administration PT, and we're working together to get them more involved.
Yeah, I mean, it takes education, right? We're not used to doing things, and so it makes us nervous. But I think, conferences like this and then starting to do things little by little, if the nurse got the patient up and they did fine.
But there's not a specific one for them. I guess there's not just a specific training.
well, now you're saying that you all are starting to work with them to say this is what we're trying to do. Is that what you're saying?
So there's a collaborative effort at TASE separately from the institution, but some of you are crossing over to sort of learn best practices and have some continuity of stuff.
Like, I still go to, like, involved with the Charleston too, but we're pulling our PT in.
Pull them along.
Being part of shared governance, and each unit, each floor is supposed to have a representative. I believe at our next month meeting, PT is supposed to be there to bring some of these devices so that the 2 shared governance reps that's from your department unit will see and do some training on that.
Can they try them out?
I'm sure they'll ask for
Who's getting on the Sarah study? I want to go in the Hoyer lift one day. All right. Any other questions?
Up here in the front.
I'm coming.
Hey, why do we not, oh yeah, I'd want to, can I hold it? Yeah. Okay.
I want to hold it.
Why do we not utilize the cardiac chair on the bed more?
He's talking about the position. Here, I can answer that for you.
Sorry. What? No, it's fine.
Okay.
You mean like the chair position on the bed itself? That's a great question. Most of the time when I'm like, can we put them in the chair position, they'll be like, oh, this bed doesn't do that, or this bed acts weird on it. That's been most of the time. Oh, they absolutely do it. I've seen some where they start doing some weird stuff, but they're supposed to do it. But I think it's just a matter of just education and culture or stuff with it, just to get used to it. I mean, I think if we just said, if they can't get out of bed but they can sit up, let's do it. Let's do it in the chair position to eat and make a difference with that.
I can piggyback off that. As an occupational therapist, and when we try to I'll put them in that chair position, and I always have to say to nursing, now it looks very scary because it puts the bed way
Super high.
And then, shortly after, I think it just is, the nurse is uncomfortable with how high that is, and so it gets put down. So it just has to raise them up so high in the bed to get those legs down low. And so maybe just more education about that or how to make that safe. But
No, yeah. that'd
Sounds
be
like we
great.
should use that position more often. All right, any other questions? Going once, going twice. Sold to the lady in the blue dress. Okay. All right, thank you guys. We're going to do a whatever minute break.
and then you're good to go.
Okay.
Check, check, 1, 2.
All right, guys. Did everybody pee in the potty? Yeah? Is my mama coming out in me? Everybody get a potty break? Everybody got some water, some snacks? Everybody good? We're awake? We're energized? We did a couple of laps around the Sim Center. Our next talk, couple of talks, excuse me, is going to be about, need a drink? I didn't get a drink. Is about ERAS. First, we'll have Andrea Schertzinger. She graduated from Marshall University with her Bachelor's of Science in Nursing, and then Chamberlain University with her Master's in Science in Nursing for Family Nurse Practitioner. She has 17 years of experience in healthcare, working initially in the operating room as a circulating and charge nurse at Cabell. She's been a nurse practitioner for the last 8 years, working in trauma surgery until becoming CAMC's ERAS coordinator. Andrew was instrumental in developing our ERAS protocols amongst multiple different service lines at CAMC. So she'll be talking to us about the concepts of ERAS in general and the implementation that we have done here at the institution. So welcome.
Thank you. So good morning, everybody. Like Dr. Ely said, my name's Andrea Schertzinger. Some of you guys might know me as Andy. I started working at CAMC Memorial 2 years ago, starting the Enhanced Recovery After Surgery program. And we have currently developed 5 pathways, including colorectal surgeries, pancreatectomies, Whipple procedures, liver resections, and lung resections. So some of you guys are probably wondering what ERAS is. ERAS stands for Enhanced Recovery After Surgery. It was developed in the early 2000s by a colorectal surgeon who challenged the traditional surgical pathways that were not supported by high levels of evidence. There's been multiple surgical pathways developed since ERAS first came about, but ERAS is a set of evidence-based protocols aimed at minimizing the stress of surgery and optimizing patient care. It begins before admission and continues post-operatively well into discharge. So ERAS has multiple benefits, but here's a few, which is decreased length of stay, which ultimately decreases the cost, improve patient outcomes, reduce infection rates, decrease complications, decrease in opiate use, and minimize the stress response of surgery. The ERAS protocols include carbohydrate loading, goal-directed fluid therapy, multimodal pain regimen, early nutrition, early ambulation, a routine bowel regimen, and post-op nausea and vomiting prevention. So in the next couple slides, I'll be explaining the impact each of these have on ERAS. So as I mentioned earlier, ERAS is aimed at reducing the surgical stress trauma. Surgical trauma induces a stress response which involves a series of physiologic reactions on the body. During surgical trauma, the body releases an increased amount of stress hormones and inflammatory cytokines, which then increases the production of glucose while decreasing the glucose uptake in the peripheral tissues, causing hyperglycemia. And patients can become insulin resistant for 3 to 4 weeks post-op as a result of this trauma. So how do we reduce the stress of surgical trauma? Well, one would be prehabilitation, preparing these patients to go into surgery. Secondly would be patient and family education. Third is implementing a multimodal pain regimen. And fourth, reduction in the preoperative fasting. So the first protocol I want to discuss is carbohydrate loading. Carb loading can begin the night of surgery and continue until 2 hours pre-op. So here at CMC, we use Boost Breeze. It's a clear liquid that we provide the patient to drink the night before surgery and then the morning of surgery. We usually tell them to drink that on their way to surgery because typically they have to be here 2 hours prior. And the new guidelines are as clear liquids up until 2 hours before surgery. So pre-op oral carbohydrate loading decreases the stress response on the patient. It reduces anxiety, reduces thirst and hunger, It also reduces the incidence of insulin resistance, increases patient satisfaction, and decreases post-op nausea and vomiting. So without the carbohydrate drink and prolonged fasting, the effects of insulin resistance can cause delayed wound healing, increased morbidity and mortality, and prolonged hospital stay. So the next is goal-directed fluid therapy. So historically, fluid regimens have been very liberal, meaning they were given large amounts of IV fluids intraoperatively, and this was partly because the patients were presumed to be dehydrated going into surgery due to the prolonged fasting. But since implementing the carb drink and limiting the preoperative fasting, this has changed. So goal-directed fluid therapy is essential in ERAS to decrease complications such as like impaired coagulation, pulmonary edema, poor wound healing, infection, bowel edema causing prolonged ileus, and cardiovascular complications. And below you'll see a formula that they use as a guideline for the fluid administration intraoperatively now. So multimodal pain regimen. It's aimed to control the nociception utilizing different drugs for better control postoperatively and reduce complications of opiates. And this consists of a multiple opioid-sparing strategies such as regional analgesia, which we have initiated for our Whipple procedures and liver procedures, that is tap blocks, epidurals, and spinals, but for those procedures we utilize the tap block. We also implemented Tylenol around the clock, added NSAIDs and gabapentinoids. So why multimodal versus opiates alone? Well, it reduces the post-op nausea and vomiting. It provides optimal pain management, reduces post-op complications such as ileuses, decreases hospital delirium and urinary retention. It also promotes early nutrition and ambulation and shorter hospital stays. So in the past, it was believed that routine NG tubes and/or abdominal drains reduced complications, prevented post-op nausea and vomiting, improved bowel functioning, and decreased length of stay. But it has been proven that, in fact, early removal actually reduces patients' pain levels, prevents complications, promotes early return of bladder and bowel function, promotes early nutrition, increases mobilization. So it is recommended to remove these lines and tubes as early as possible, meaning intra-op. So when we think about early nutrition, we think about patients starving before surgery, but this has become a thing of the past. It's been proven that oral nutrition can be initiated as safely and early as 4 hours after surgery for the ERAS patients. Early nutrition leads to shorter hospital stays, less infection, and improves patient satisfaction. It also improves the gastrointestinal integrity, early bowel function, and supplies the body with the nutrients needed to support healing and prevent the loss of muscle mass. So I know the other speakers have touched on the early ambulation, but I'll briefly go through these next couple slides and tell you a little bit about ERAS and our goals for early ambulation. So it's evident that prolonged bed rest is an important risk factor for postoperative complications and morbidity. The definition of early ambulation, though, differs among different providers, but in general it involves sitting, standing, passive range of motion, and walking that is initiated the day of surgery. For the ICU ventilated patients, this may include respiratory PT, which is like chest percussions. So ERAS recommendations for early ambulation include getting these patients up the night of surgery, whether that's just walking them to the bathroom, letting them wash their face, brush their teeth, standing next to the bed, anything to get their body up and moving. And then the next day, up to a chair for each meal and ambulating at least 3 times a day. So the benefits of early ambulation are it stimulates circulation, decreases length of stay, decreases complications such as pulmonary complications, muscle atrophy, infections, and cardiovascular deconditioning. It also reduces the risk of ileus and promotes healing and independence. So as they said before, some of the patient-related barriers to early ambulation is expectations or the patient's refusing to get up. And that comes with educating these patients ahead of time that that's what we expect of them after surgery. Increased pain, and that's why we implemented the multimodal pain regimen. Nutritional status, obesity, delirium, and fatigue. Some of the structural barriers to early ambulation is limited staff, which we have all discussed that and know that that's an issue on all floors. Time constraints, lack of staff training, and limited equipment. So some of the solutions to these barriers include the ERAS protocols, such as the multimodal pain regimen, implementing an ambulation protocol, pre-op patient education, a sleep protocol, staff availability, and staff education and training. Next is stimulating gut motility, so implementing a bowel regimen. So we know in the hospital, having a bowel movement is probably one of the most uncomfortable and possibly embarrassing moments for a patient, but is so beneficial for the patient, and the complications that arise from constipation are endless. So ways to promote bowel function is, again, early nutrition, the mobilization, get these patients up as soon as possible, initiating prokinetics such as Interreg or erythromycin, routine bowel regimen, starting that immediately post-op, chewing gum, which is a form of sham feeding, so it's actually stimulating the gut without actual food, and then using NSAIDs versus opiates. So here are some of the complications that can arise from not implementing a bowel regimen, and that is bloating, post-op nausea and vomiting, increased pain and abdominal distension, and ileus. So I've provided an X-ray image of what an ileus actually looks like, and this is one of my biggest pet peeves taking care of patients in trauma is they all end up with ileus because there's not proper bowel regimen. And then treating a ileus is much harder than actually preventing it. As you can see, there's multiple air and fluid levels in the small and large intestines. And an ileus is extremely uncomfortable for these patients. It increases their length of stay due to delay in nutrition, delay in bowel functioning, and causes nausea and vomiting. They ultimately end up with NG tubes, they're NPO, and they're just miserable. This is a result of increased opiates, minimal ambulation, and little to no bowel regimen. So the last protocol, reduction in post-op nausea and vomiting. In order to reduce post-op nausea and vomiting, we can utilize the APFEL screening tool that consists of several risk factors, such as being a female increases your risk, non-smoker, which is surprising to me, history of motion sickness and post-op nausea and vomiting, and use of post-op opiates. It is recommended by ERAS for patients to receive at least 2 agents for prophylaxis, and these could include Amend, Zofran, dexamethasone, scopolamine, and Reglan. Other ways to reduce post-op nausea and vomiting include avoiding nitrous and using anesthesia induction agents with short-acting opiates, also implementing the multimodal pain regimen, early nutrition, and early mobilization. I'm going to grab a drink real quick. Sorry, my mouth is dry. So last but not least, I wanted to mention prehabilitation and what it means for ERS. Prehab is extremely important. It can begin 6 weeks before the patient even goes to surgery, and it consists of smoking cessation, alcohol cessation, nutrition counseling, anemia prevention, sending these patients for iron infusions, cardiopulmonary testing, glucose monitoring, and anything else that is involved in optimizing the patient's surgical outcome. It ultimately improves the patient's functional capacity and enhances post-op recovery. So I wanted to give an illustration of how I interpret ERAS and the importance in the surgical process. And I think of it like a hurricane warning and not knowing what to expect or how bad the damages will be. But if I think about it as having like a strong, sturdy, well-built house when you go into surgery, so meaning your body is in its best shape, then the damages will be minimal. But if I have a poorly built house that is barely standing, the outcome obviously could be detrimental, which is this next slide, a patient without ERAS. So as you can see, the damages are pretty irreparable. So if a patient goes into surgery in their best shape, the quicker they will return to their pre-op state, while those who present poorly likely end poorly and take longer to recover with increased complications. So if you apply all the elements of ERAS and follow these protocols with your patients, they will have the best surgical outcome and the least amount of stress response. The patients will have less pain, shorter hospital stays, quicker recovery, which ends up with happy patients and increased satisfaction. The ERAS protocols, they require little changes to our everyday practice, but they greatly impact the patient's outcome. So ERAS has been implemented in several surgical specialties with great success already and continue to improve over time. Thank you for your time and interest. I hope I gave you guys some insight into ERAS and what it's about. If you guys have any questions, feel free to ask.
Anybody have a question about ERAS just in general?
The multimodal pain regimen that has the Neurontin in it, do patients go home on the Neurontin? Because I've had patients say I was not on that and it's addictive, and do I go home on it?
So typically, no. We have not been giving them scripts for the Neurontin post-op. And most of these patients are only here 7-9 days post-op. So typically they don't need the gabapentin. You can send them home with gabapentin. It's not going to hurt them. And if I do, for example, my patients with trauma, I will send them home for a week or two and kind of wean them, because they say after 7 to 10 days you probably do need to do a weaning process.
I think that's a good point. Just like the antipsychotics that we talked about that patients go home on and then they never get stopped, gabapentin is one of those that continues then indefinitely without a real plan. And so for our patients that are post-cardiac surgery, we actually only give it to them for 5 days because we don't want them to go home with some of these things. So we'll learn about cardiac ERAS here in a second. Any other questions? Come in, Bob. No, it's fine.
How does early carbohydrate loading decrease insulin resistance? What's the mechanism?
Gosh, that's a tough one. I've looked at it multiple times. So maybe you can help me, Dr. Ely, with the...
It
basically,
just does.
It
Do you know the answer?
I guess I'm not 100%. I thought the idea was that just because they're MPO for so long that they were going to have.
I thought that when being MPO for so long, there's an increased stress response,
Yes,
and
that's
then you have a higher glucocorticoid action that makes more glucose be made, and I'm pontificating. I don't know.
That is the general census, is it causes an increased stress response for these patients being fasting for so long. So then that ultimately causes the release of the hormones and the cytokines, which cause the increase in insulin, and then decreases the uptake within the peripheral tissues, and that causes the hyperglycemia.
I think there's, I don't know the exact response, but I know that there is, from the outpatient standpoint, our number one complaint for patients, even after they were, it's I'm starving, and then it's hard on people. A lot of our patients are already on a PPI at home or Zantac or something like that, and then you try to go with an empty gut after you already have gastritis for so long, and then you try to feed them by the time they actually get out of surgery, and then it's painful to eat at that point. So then they can't eat, and then they're telling the nurses, I can't eat, and the nurses are telling them, hey, you need to have a bowel movement. Well, how do you want me to have a bowel movement if I can't eat? And then you're trying to feed me lasagna, and then that, it's like this spiral. And by the time they get to us after discharge, our number one call was, hey, I can't eat. What do you mean you can't eat? Have you eaten since you had surgery? No, not really. And it's like, okay, well, it's now 3 days after you've been home and you still can't eat. That was our number one call. And whenever we finally started the Boost Breeze, it was like that call went away. That between that and talking to the nurses, the post-op nurses about, and the families about bringing different foods that were actually comfort foods instead of, something that they would eat when they're sick and their tummy hurts at home and they've been throwing up and yada yada. That's
Not a McDonald's
yeah,
cheeseburger.
not pizza, not not the junk. And then you just kind of gradually start to eat. That really changed things. We don't get those calls anymore. I'm telling you, we do not get those calls anymore. And that I was so surprised when I found out that was our number one call. Couldn't believe it. So that's anecdotal, but
31 years of looking at patients and diabetic diets, which this hospital does a horrible job of, and we all know it. Something needs to be done with that, honestly. I mean, I have patients that say, I'm a diabetic, I can't eat this. You talked about the lasagna. I said the first thing that we're trying to give people post-op is spicy stir-fried chicken and rice. I mean, it makes no sense.
it makes no sense.
And then
How
we're,
can you not eat that when you just woke up from surgery? You haven't had anything in so long. You can't handle it. You don't want it. The smell makes you sick.
and I think looking at we need to address that from a dietetic standpoint, because people can't eat when they're served the food that we're trying to serve them. It's ridiculous. But I gave up about 10 years ago.
It doesn't stop her from talking about it, though, all the time with me. I have a question, too. Does somebody else have a question?
Gina.
Oh, while I'm walking back. So, always and forever, right, we have anesthesias like, oh, no, NPO after midnight, if they take even a look at anything in the last 12, 18 hours, we're not doing it, right? How are you able to get that buy-in and that huge shift from what we normally see in patients where they have to be NPO forever to like actually giving them something 2 hours beforehand? Because that seems like a huge drastic change. How were you able to do that?
Actually, it was very easy because anesthesia was on board, and as you research, anesthesiologists are the ones that came up with the new evidence that you don't have to stay fasting for as long as you did prior. So you can have solid foods 6 hours and clear liquids up to 2 hours. So when I mentioned that we were going to start doing this, they were all for it. I didn't get any kickback from them whatsoever, and they've been supportive. So we've been doing, and I initially started just doing one Boost Breeze the morning of, but then I added the additional the night before, because a lot of the other institutions are doing that and it's working. And we all know that that's the worst thing about going to surgery is not eating and not drinking.
Well, and like if you're an afternoon case and you've been NPO after midnight,
yes,
it's hard.
So this might be able to answer Dr. Crasali and your question about anesthesia, because the colon surgeries, and I can only speak for colon because that's the only one that I helped initiate. Probably over 8 years ago, Dr. Dyer, that was one of the things he wanted as part of the colon bundle that was initially from ERAS, was to start that pre-carb loading drink, and we did it for all patients, diabetics or not. So they had that the morning of surgery. We spoke, we worked intensely with anesthesia at that time, and I don't think they were on board at the other hospitals, but majority of our cases were at Memorial, and they were. The Boost Breeze was a clear liquid. They had clear liquids up until 2 hours prior to surgery, and I don't think that they had any that they canceled just specifically due to that. So.
I guess.
Is the
Is Is it another hard one?
You're sort of still my boss in a way, so.
Is the carbohydrate solution icky sweet, like sugary, or is it complex carbohydrates?
Oh, we should have totally had samples.
So it's,
Thank you.
well,
It should have been our snack.
it has
My medical
50
samples, right, thank
grams
you.
of carbohydrates in it. And from what and you know what, I've been meaning to try it myself, but I did.
Tried it. I've tasted it.
Is it
Is it the
sweet?
peach one? Don't do the peach.
I think they say it's got a little bit of bitter, but it does have 50 grams of carbs, or 40 to 50, and that's what they recommend for the carb loading. Yes.
And there was a
And
comment
it's
over here.
safe
You
for
can.
diabetics. From what I understand, that they even give it to the diabetic patient, unless they're a severe brittle diabetic, then you might want to go to something like a Gatorade Zero.
And you can substitute Gatorade, actually, was the comment up by there.
If there is in-house, it's pretty often, we get that from dietary, because it's not.
Yes.
They call somebody
Yes.
dietary, they'll bring it up.
Because that's exactly where they get it from for PAC, is they just call dietary and get it. And so you could just call them. And the same thing as the other Boost Breeze, but this one's a clear liquid.
Where will that roll out on, and where do you anticipate rolling that out, like the heart surgery patients? We are doing this. All of our.
Hey, look, what a great segue, Carolyn, into our next talk.
We are doing it for all of our outpatients. Our inpatients, we have started doing it, and that's the recommendation.
Yay,
Now, the
you did great.
inpatients,
That's
the
awesome.
outpatients, we started
I got
doing
some
the
pictures when I
midnight
just like.
dose and the 2 hours before, which is always tricky. Sometimes when the cases get moved around, but we try to really tell the patient, and we give them to the patient beforehand. So we give it to them in the office. Make sure that they have it in case something happens, just keep it at your house in case, PAT doesn't give it to you or whatever happens. That way they know, and the family's in charge of it too, so the family will make sure that they get in it. And that's the big thing, is make sure you get this in 2 hours beforehand. You're done and completed 2 hours beforehand. And all of the surgeons are on board with it.
Oh, she already mic'd up. All right, next, or now, or already that has started, is Jennifer Ogren. She began her nursing career in 2017. She initially led a startup project for preventing readmissions for acute MI patients, which led to a dramatic reduction in our readmission rate at the institution. She then started up a program specializing in monitoring of thoracic impedance in patients with implantable defibrillators in order to prevent decompensation of CHF. That sounds very technical.
Yeah, it's fun.
As those programs continue to evolve and transition to new stages, she's currently working on developing a new hypertrophic cardiomyopathy clinic at CAMC Cardiology, and she's developing our ERAS quality program for cardiovascular surgery. So Jen will be talking with us about ERAS implementation within the cardiovascular surgical space today and some of our outcomes. So welcome.
Thanks. All right, well, I've already blabbered quite a bit. Thank you all for having me. It's actually nice to see people like in a room together, not over Zoom. So this is amazing. Makes me very happy. And at some point when Dr. Ely gets back, I want to make sure I get a picture of everyone because she's adamant about getting a picture. So the first thing that I know we already talked about ERAS. If you haven't heard the term ERAS, glad you're hearing it today, because I hope the whole hospital is talking about it. It's a really great initiative that the hospital has been doing for 2 years. We've been doing it for 1 year now in CV surgery. And it's kind of a combo for CV surgery. So we also have what's called STS, which is the Society of Thoracic Surgeons. And I don't know if everybody has heard of that or not, but basically it's a national database that it's a quality improvement initiative. And it's all about patient safety, and they give us a bunch of guidelines that we have to go by. And so that's our primary precursor. Now, there is an ERAS Cardiac Society, and they presented, so when we first started this, everything was kind of separated, and it's like, okay, well, we're gonna have to figure out how to morph these two. But now, in 2024, this year, they came out with a collaboration between the two. It's called Perioperative Care in Cardiac Surgery, a joint consensus statement by ARAS Cardiac Society, ARAS International Society, and the Society of Thoracic Surgeons. And basically, they had to go under formal review to get this approved, and that is our new guidelines that we follow. All of these, which Andy has already talked about, reduces surgical insult, promotes recovery, prevents post-op complications, and improves value of delivered care, which is a big deal for all of us, right? I want to talk about our STS quality ratings because this is a big deal. Our institution does do this. It's our starring system. Basically, you have 3 stars. 1, not so good. 2 is your middle ground, and 3 is exemplary, and we are 2 across the board. So unfortunately, it does across multiple years, so we are working on getting to 3 stars. And this does everything like absence of mortality, absence of morbidity, and those, we are starred on all of these. So if you have a stroke, CVA, if you have deep sternal infection, prolonged intubation, which is like greater than 24 hours, renal failure, which is 3 times whatever their baseline was, or if they initiate dialysis, or if the serum creatinine reaches above 4, or if they have to be reopened for any reason. They have to use an internal mammary artery of some sort, and then we have to make sure that we give the appropriate medications pre-op and post-op. At discharge, they have to be discharged with the appropriate meds, and we are rated on that. So I want to talk about our beginning initiative. Can everybody hear me all the way in the back? Just make sure. Okay. So I went with Dr. Alware came to me initially when I started this and asked me to start our cardiac ARS program. And I went with our administration to Wake Med. So Wake Med was really interesting because they have the first cardiac ARAS program. And at the time, ARAS was everywhere, all of the other disciplines, but they said that it couldn't be done in cardiac. And this one nurse said, yeah, right, it can too. And she found some surgeons that came on board, and they initiated a program. It was really successful after their first year. And until this year, when we got our new guidelines, it was always running after what they did. So basically, they laid the groundwork, and it was a great program. So this is where we started. This is what we were given. It's basically 20 initiatives, and it's like, okay, let's go. What do we want to do first? So the biggest thing, though, out of it was, first thing, building your team. And let me tell you, I got one heck of a team, because a lot of them are right here. And we really went after it. And building our team was a lot of different people. And then we chose basically like 5 to 7-ish of these when we started, and we're like, okay, we're going to go really aggressively after these. I think we got a little bit happy because I don't really know any of these that we're not doing, or at least in some capacity doing. So that's actually pretty incredible and way above what I thought we would do in the first year. So we really followed the pioneers, but it was getting the surgeons to agree, which all of our heart surgeons at CAMC do agree with this program and agree, and we all get together for meetings all the time. We have quality meetings in order to analyze every new move that we make to make sure that everybody agrees. And sometimes they don't agree. And then we come back to it and we readdress and we find more data and then we come back. We got administration on board, anesthesia, nursing, pharmacy, and we really found our intensivists were vital in this, and we really found that we were able to create this, in Dr. Ely's terms, village, and then we were able to really implement the full program. And then we just do routine auditing through these meetings and make sure that everything is what we want it to be, and we're getting the quality that we want. I just wanted, before I really go into it, I want to talk about the point of this again and our goals. Reduce that length of stay, reduce surgery complications, readmissions, And then, of course, our quality indicators for STS, and then just patient satisfaction. The first thing that I want to talk about that we really hit hard on, and probably my biggest initiative, was prehab. And I didn't really know what is prehab. And I have a lot of dreams about what I wish prehab could be. But that was really our first go-to. And that's when I went to our amazing nurses at Open Heart Recovery and talked to them about what they thought that we could do. And then I went to our office and I talked to the patients pre-op. I went and sat with all of them to see what they were feeling, what they were going through in the beginning, and then how they followed up on that with their discharge. What were their questions? And we went through and wrote down every single question, every single phone call that came through that office. I went in with all the patients at their first appointment at the 3-week mark to see what their difficulties were, to see what they really wanted to do, and talk to all of their families. I talked about earlier that post-op nausea and vomiting. Could not believe that was the biggest issue at discharge. I always figured it would be CHF issues. That was a lot, that was common, but it was really that I can't eat. But there was such a level of fear going into surgery that I was really surprised. And I really couldn't figure out why there was so much fear involved with going into surgery. And it was really, there wasn't, the surgeon would come in, talk to the patients really quick. There would be like a horde of people come in and talk to them. Sometimes their family would be there. Usually they would. And I know how it is when a doctor comes in and talks to you and you don't really understand anything and you think of all these questions you want to ask, and it's so fast and so quick, and you really forget to ask everything. And then they're in and out and they're ready and they're signed up and ready to go, and boom, that's it. And they really don't know what's involved. So what we did is we came up with this huge booklet, and it's like a big monster thing that we could give to every single patient. And I manually print all those things because I'm still waiting a year later for our marketing department to get it to me. And this is something that is everything you could ever imagine as a part of it. And it's true pre-op counseling. We redesigned the clinic so that we could free up a nurse at all times. That way that nurse can just go, there's somebody in the clinic, but then she can go tag, you're it, to that nurse if they have a new patient. They come in, they sit down with that patient for an hour, that family for an hour. They come in and talk to everyone. They make sure that they understand every piece. The surgeon is still there. So if there is a technical question that surgeon needs to ask, that patient needs answered or that family member needs answered, they just run back, grab the surgeon, he comes back in, he talks to him. It is true what you would call shared decision making, because now the patient and the surgeon are on the same grounds, they understand every piece of it, and they can truly make a shared decision that, yes, I think this is a great idea, I want to go through with this. As part of that education, we really hit and hone on tobacco and alcohol cessation. And it's surprising, if you use it as ammo, heart surgery, especially in our community, is a really big deal, right? It's scary, and the patient is scared. They're scared for their life. They're scared if they're going to be alive on the other side. So we use it. And we ask the patient, we're like, look, if you stop smoking, or at least cut it in half by the time you get to surgery, if you give us these 4 weeks of nothing, it'll change things. You have a much better chance of how you recover on the other side. And that fear, we use it. And it actually works. We've gotten a lot of people to stop smoking, and then they quit smoking on the other side because they're like, well, I stopped for 4 weeks, I might as well. What's the difference? So that seems to work pretty well. This is really getting into our nursing education during that first visit, that 1 hour. And it goes back to what Dr. Ely was talking about with that family member. It's really about getting the caretakers involved, because remember, when the patient leaves, now it's their job, and they're scared to death. And just to bring it home, my dad just recently had open heart surgery here. Everybody took care of me probably more than him. because I was a wreck. And it's nerve-wracking. It's all of a sudden it's on you, and everybody's coming to you, and it's like, what if I miss something? What if I slip on something? What if I don't recognize something? What if I'm not there if something happens? And that's how all these family members are feeling. Probably worse for me because I know enough to be dangerous, but not enough to do anything. But it's still that main person, whether it be their wife, whether it be their husband, whoever it is, that person's responsible for them. So if you can utilize that and teach them and actually make them feel good that they know how he should be getting up, when and how, and they're part of it, then by the time they get home, it'll be no big deal. It goes back to practice we're talking about with PT and OT as it is with those patients. It's just getting used to it, and if they get some time with it, they'll get used to it. This has really been our big thing when we talk about prehab, and it goes into talking about disease process. We bring out the samples so that they know how to take care of the wounds pre-operatively before they ever even go in. We do nutritional counseling, screening, making sure that we get them in with a dietitian if they need it. We talk about everything to expect after surgery, after discharge. We talk about cardiac rehab. We make sure that they have all the equipment at home to be able to monitor their vital signs and make sure that they know how to do it. And then we make sure they understand what kind of appointments they're going to need to do, how often they're going to need to do it, and what their recovery is going to be like. In addition to that prehab and screening, we get into lab work where we're looking for anemia, which we talked about earlier, where we're looking for malnutrition. We're looking for that A1C, making sure that we find oftentimes undiagnosed diabetes, or we try to get them in with endocrine to really enhance that glucose control. We hope that in the future we can collaborate with PT and OT, which I would like to talk to you at some point. And then that way I can make sure that our nurses in the office really know how they need to structure that, because we're trying to teach them what to expect and how to move before they even get into surgery. That way they know what to deal with and how they can get themselves ready. We talk to them about preparing their homes to make sure that their home is clean, showers are clean, everything is scrubbed, how to get everything ready. And then Dr. Ely had the initiative to go after the incentive spirometer training pre-operatively, along with deep breathing exercises, in order to try to improve that post-op oxygenation and reduce ventilation time. Probably one of my biggest initiatives with this for the 2 years has been blood. So they want to reduce the blood use. That has been like a huge push. So what I did was call the blood bank, and we really coordinated with them in order to understand how we screen patients, which we did not do at the time, and then what we need to do in order to treat the patients to get them ready for surgery. And we really collaborated both with the blood bank, with renal, hematology, in order to make sure we're getting iron infusions beforehand. We do them inpatient and outpatient. And then if we need to, vitamin B12, folate, any kind of nutritional adjustments and that sort of thing. That has actually been tremendous. We've seen really great pieces of that. The other thing that we are doing, which is a little bit odd, is we are coordinating all those referrals if we need to. We're optimizing these patients, making sure that we have time to get them optimized for elective cases. And that's with renal, pulmonary, endocrine, hematology, PCP, CHF clinic. And then we're having multidisciplinary meetings between cardiology, surgeons, imagers, in order to make sure that we're planning well for these surgeries and making the best decisions for the patients. We also have kind of a new piece that we are trying out, and it's an ARAS cardiologist. He's actually a wellness cardiologist, Dr. Chakalinga, and he's seeing our patients basically a month before surgery, and he is optimizing them. He is quite the gentleman if you haven't met him yet. I'm sure if you walk by him in the hallway, he will start talking to you and tell you about the world. He has a way with patients, and he not only is able to optimize their blood pressure, optimize their weight loss, trying to get them ready for surgery, which we've had patients that haven't been able to have surgery, and he's able to get them to lose enough weight to now be able to have surgery, which is getting ready to happen, which is incredible. We were using that kind of as our trial run. And he can also optimize their glucose control, and he does ketone monitoring too, which is a whole wild thing that I don't know anything about, but it seems really fancy. Next is really getting into our pre-op phase. Now this part was easy for me because Andrea had already set it all up. So that's where we're doing the boost breathe that I talked about earlier. We stop all of our medicines now concretely at these times with the ACE and the ARBs, the SGLT2 inhibitors, and the GLP-1, which was a little bit of an argument from endocrine, but now anesthesia guidelines, hard stop with the GLP-1 agonist 1 week prior to surgery, which was definitely helpful. I know when you're looking at the risk of the boost breeze too, I think that was part of the argument with that too, is delayed gastric emptying and the use of the TEE also increases risk for cardiac surgery patients. So it was helped trigger the stopping GLP-1 agonist 1 week prior to surgery. Intraoperatively, so our I know that the surgeons are doing a lot on their behalf intra-op to make sure that things are really pushing forward, especially they're doing a lot right now with infection prevention. But a big push for Dr. Ritchie and I was really talking about intraoperative fluid management, that goal-directed fluid therapy. There was really a lot of excess fluid administration given. And a lot in this process, they were using a lot of normal saline, and excess chloride was definitely a problem. A lot of blood products, which we talked about earlier, we were able to reduce that. And it's really about creating individualized fluid management plans. They switched to Normasol. And so now that is stocked in the OR. I believe it's stocked in open heart recovery now too. And that was like a big push in order to try to prevent this and really trying to calculate how much fluids. Do you feel like there has been a big change? Yeah? Yeah, good. And then Dr. Ely talked about earlier with the Precedex too, is definitely helpful. This is kind of a different piece that some of our surgeons are doing, and it's a sternum device. And it kind of leads into me talking about sternal precautions. It's a Sternalock 360, and basically instead of just wires, it's a plate and a band system. And you can see it goes all the way around the back of the sternum, which is actually pretty neat. It helps so much on stability. Those patients, and it actually screws in. So they basically take this ribbon, tie it around, and then tighten it, and then screw these plates on so that it's more stable than just wires. I have noticed, I know there are studies to show, but when you actually see it in action, the patients that come in at their 3-week follow-up, if they have just wires, they definitely don't feel as comfortable. But the people with the plates, they're like ripping their shirts off, and you got to be like, woo, you can't move like that yet. They feel great. There's so much, they feel more stable. I don't get the complaints feeling that it moves a little bit or it bothers them when they sleep at night. It's been wonderful. So that's been a big push. And when we started pushing that, we really started talking about sternal precautions. So before, you can't lift, you can't push, you can't pull more than 10 pounds, you can't push up to get out of the bed, you can't raise your arms over your head. There was so many limitations. Can't reach behind you. We've talked about it, and really in the office, we're moving toward what's called keep your move in the tube. And this was developed by Baylor. Sternal precautions don't actually have really any origin, and there's so much discrepancy between them. So Baylor went after this. They did like basically a TEE to measure pressure in the chest and what caused the most pressure. A cough and a sneeze were the worst. I think a cough was 90 pounds of pressure, a sneeze was somewhere right under that. That's a tremendous amount of pressure, but nothing in the movement was causing that much pressure. So the worst pressure that you're going to get on that sternum is your cough. So they said, as long as you keep your move in the tube, basically they put a tube, a hula hoop around the patient, and they say if you stay in the hula hoop, you're good to go. You have to do everything, you base it on pain, so your movement level is based on pain, and you have to do it with both hands. So if you're going to push the door, you have to push the door with both hands. So now all of a sudden they can actually live life a little bit more normal. We've seen huge changes based on that. People come in so much more confident. They're not, I think the biggest problem is you would see people come in like weeks later and they would still be like hunched over, especially the little women. They're in there like, I'm in so much pain in my back because you've been sitting like this, protecting your chest, not moving for weeks. So I think this actually gets them moving a little bit. It makes them feel much more comfortable, and then they actually want to get up and move around. Post-op phase. This has really been Dr. Ely and Dr. Ritchie's world, and they have done all of these beautiful bundles in order to get our patients extubated early, which the goal is less than 6 hours, and I believe that we are there, or if not, we're very close. Going after the multimodal analgesia, delirium prophylaxis, keeping those lights on, daytime hours, waking hours, keeping everything on, and then pulmonary function optimization, which Dr. Ely talked about earlier. This early mobilization is really probably the key to everything. We follow everything that Andy talked about earlier with acetaminophen, gabapentin, Oxys 5, unless we need to scale up to 10. And I think actually the coolest thing about that initiative is really that the patients are asking for the drug, because at first they're watching their clock, like, yep, it's time, I need it. And then they start getting distracted and life gets busy, and then they stop paying attention to their watch, and it's not 4 hours anymore. All of a sudden it's 6 hours, even though they thought they needed it at 4. And then they are pushed out a little bit, because as long as those tubes are in, they're very painful. So it's getting people kind of over that mental hurdle of you really don't need it as much as you think you do. We have our bundles for glycemic control, post-op nausea and vomiting, which follow what she talked about earlier, bowel motility, and then diet. We start with ice chips and advanced diet as needed. And then a new kind of cool thing is the gum chewing. We do that pretty much before every meal. We try to encourage them. And patients kind of look at you like, why'd you give me a pack of gum? But once you tell them, it actually gets their gut stimulated, and what peristalsis gets that going. And then they want to eat, and they actually get hungry. So if we're looking at specific for cardiac, we really have a lot of AFib prophylaxis with our beta blockers, our amio, our MAG, Renexa steroids, and then we have those pleural flow chest tubes, which are pretty neat, and basically they proactively remove clots without stripping or breaking the sterile field, which is pretty neat. Dr. Tobar calls them the fancy tubes. And then some of the surgeons, they also do a posterior pericardiotomy, which is an incision that allows prolonged drainage that's of dependent blood into the left pleural space, which is thought to be irritating to the left atrium. I wanted to bring up the AKI prevention and diagnosis because I know that's been hit heavy. And that's when it's earlier identification preoperatively is one thing that we're hitting really hard in the office. That way we know the patient is high risk for whatever reason. And then after, for post-op patients, we use a VEXA scan, which is actually, I think it's like fantastic and it's really neat. But basically it's a venous excess ultrasound, and it's a scoring system for the severity and treatment of venous congestion of the IVC, the liver, the gut, and the kidneys. And we start that, post-op day 1? Yeah. I want to hit a little bit harder on the ambulation. I know everybody's talked about it today, but I think it's phenomenal. Sounds like everybody here is like ready to rumble, a little bit scared, maybe. But it's we've got some new assessments with the MOVES assessment first, see if the patient is stable enough to move. The BMAT, again, like we talked about earlier, analyze the safety of moving and the method you're going to do, and then at least get the patients walking twice a day. When I first started this, I think that was a huge barrier to cross. And I think talking to all the nurses was definitely very interesting on how you could juggle around times in order to try to get the patients up. But we did hear some pretty cool anecdotal. I wish I had like concrete things, but our STS scores are not back yet from 2023. But we really have had a change in the mentality of patients where we've talked to them pre-operatively. We don't have patients complaining anymore. They know when they are going to get up, when they wake up, they get that tube pulled, time to get up. And that's in their head. We tell them that, we hit it home, we know it's gonna hurt, but this is what you've gotta do if you wanna go home. If you change that mentality in the patients and the family, then everybody is ready to go. And we did that with one patient. I will never forget him. And he made a full lap all the way around the unit on day one. It was great. And he was like, I gotta go. I gotta get up. Jen told me to get up. And then everybody yelled at me because, he was so aggressive about it. He was like, I gotta get up. But he did great. And he did great afterward. He had no problems. And that was really like, okay, we could change this from the pre-op phase. And we really need to, because then if it's not so shocking, I think they're more willing to do it. And I think a lot of this is really about, for me, is about patient education and making sure that everybody understands what they're doing. And cardiac rehab has been wonderful on getting us help for that. The other piece that we do, which we're going to hit harder this year, has been nursing calls after discharge. So basically we have a mid-level. They toss it to the nurse in the office and say, hey, such and such is getting discharged. That nurse is in charge of calling them 48, 72 hours, somewhere around that mark, enough time for them to kind of recover a little bit and be able to talk to you. They go through, they have a full script. They go through everything in the script, and that mid-level will also let the nurse know, hey, I need you to do this. They have INRs that they need checked, or whatever is new that you really need to watch out for. That way they're aware to really hone in into that. They talk to the family, make sure the family understands everything that they need to go through, and then if they need to, they will call them again in 1 to 2 weeks to make sure that they're okay until we can finally get them in the office. We have now an open door policy in the office. Any patient calls, they want to come in, we're here Monday through Friday, 7:30 to whatever, 4, come on. If you have any questions, if you want us to look at your wound, if you have any questions on your symptoms, if you want us to go through anything or you're just scared, which we get that a lot, come on, we'll go through everything. If they don't feel comfortable changing bandages, if they've got something going on, we do that. We don't care. We keep it open. We stockpile them full of whatever they need, and then we make sure that they feel comfortable to go back home. We make sure they understand what vital signs they need to monitor, and then hopefully in the future we will be including remote patient monitoring into this, which we do some for our CHF patients. They're going home with that big bulky monitor thing that sits on their side, and then a nurse there gets a hold of somebody in the office if she starts seeing anything out of range, because she's doing really the monitoring and the fancy stuff with that. And that's it. Anybody have any questions?
Is this thing on? There you go. Sounds like a lot of work, particularly as an outpatient. These people are getting a lot of education and a lot of resources go into it. We have a lot of patients that come in and to the hospital with a STEMI and NSTEMI or whatever. Are we doing anything for our inpatients that are in the hospital for 3-4 days before we're waiting for that Plavix to wear off?
Some, yes. So we are working, there are some fantastic nurses on 6 Front, and we have been working, most of our patients come through 6 Front. We will start working, once we get everything honed in on 6 Front, we will start working with PCCU also, to make sure that this same education is given to the patients and the family, inpatient, before they go into surgery. That way, when they come out to you all, they will know what they're talking about and they will understand it just like the outpatients do. So we want to make sure that that script comes across all the way.
Questions? Everybody just wants to push through. Well, this is a really exciting thing in surgery in general, not just cardiac surgery, but the bowel surgeries, the Whipples, the thoracic surgery, and I've forgotten one. Liver. Yeah, the liver surgery. So, and so it's a lot of effort, and it takes a team and strong work.
Can
ladies.
can we get a picture of everyone while I'm standing up here? Can you do a
You
little
can't
something,
just
something?
stick around for a minute?
Yeah, I can, but what before, you know.
Okay.
Let's do it. Why not?
Let's
Everybody
do
cool
it.
with a picture?
Like the whole, like a selfie
Yeah.
with the room?
Yeah. Yeah.
Awesome.
Yeah. Okay, so I need you about right here. And you can hold that up if you want, however you want to do. And everybody that's on the inside, no, up. You should point, Dr. Ely, and then everybody on the ends, put your hands up. Ready? Come on. Andy, get in here.
Oh, you guys.
Come on. Just because we work at a hospital does not mean that we're lame. Come on, guys. See if I can get everyone. I got everybody. Yeah. Okay, everybody in the back, participate. I can see all of you. What is it, glitter hands? Glitter hands! Glitter fingers, that's what it is. Oh, that's awesome. Okay, sweet. Thank you all.
So fun. Is that a game sign? Oh my gosh, that's funny. Okay. She's got your mic if you want a clippy.
This should be about 6 inches from your mouth.
Okay. I have the pleasure of introducing Ari Guarnero. There you go. He's a respiratory therapist originally from Argentina. He was first a physical therapist, actually, and then decided to pursue his respiratory therapy degree. He has multiple publications in the area of mechanical ventilation, has been an invited speaker to the AARC as well as other conferences. He currently works at the clinic, at the Cleveland Clinic Respiratory Institute, where he is actively engaged in research. We're so thankful to have him here today to talk to us about mechanical ventilation, liberation, and the interactions with the ventilator and the patient, all the way from Cleveland. So we truly appreciate your generosity and your travel all the way down
Thank you
here.
for inviting me.
Sure. Thank you. Welcome.
You don't see my cursor there, do you? No.
I don't think the cursor shows up if you use it on the computer, but you have a cursor here if you'd like to.
No, but now you see it. Yeah,
Oh,
no, that's I
okay.
need because they're gonna.
Yeah, there's this too if you want.
Okay. Well, good morning, everybody. As you know, I have a strong accent, so let me know if you don't understand me. Most of the time I say, if you don't understand me, read the closed captioning or try to guess it. You know, the funny thing at the hospital where I work, they call me Inigo Montoya. Have you ever seen The Princess Bride? Okay, don't make me repeat the line, please. Every time I go to work, I carry around my neck this pen drive. I'm one of those kind of freak guys that like to collect graphics so I can upload them after social media so we can analyze them, try to see how the patient is interacting with the vent, and sit down on, without the heat of being at bedside, and try to see what's going on and what we can do to improve the way we ventilate our patients. At this present time, all of you are breathing spontaneously. I invite you guys to take a deep breath, take another breath whenever you feel like. And you're gonna see that nobody's telling you when to start a breath, nobody's telling you when to finish a breath, nobody's telling you how long the breath should be. There's nobody pushing the same flow in your lungs. You decide how long it takes, how the flow is gonna be. Everything is variable. At this present time, our breathing muscles do the work of breathing. The work of breathing means that the muscles gonna be doing the work to make the air go through this little straw and expand this little balloon, which is a simple representation of the respiratory system. Down here, we can observe the equation of motion, which is the mathematical representation of the balloon and the little straw. What we can see on the lower part, resistance times flow, if we multiply them, it's going to give us the units of pressure. That means the pressure necessary to make the air go through our upper airways and lower airways, in this case, this kind of straw. And if you get the elastance times the volume, it's going to give us the pressure we need to expand the chest wall and the lungs. So in a few words, our muscles have to do the pressure necessary to make the air go through our airways, and after that, expand the respiratory system. The whole patient-ventilator interaction goes through 3 levels or 3 processes. The one that we describe right here as breathing spontaneously, and the way we want to make our patients breathe after we extubate, we get the muscles doing the whole work of breathing. Just after intubating somebody, the patient is going to be paralyzed or is going to be deeply sedated, so P-mask is not going to be in the equation. The whole work of breathing is going to be done by the vent, what we call P-vent. P-vent is the pressure that the mechanical ventilator has to do to make the air go from the vent to the patient. In a few words, it's the same kind of pressure that has to do to make the air go through the circuit in the tracheal tube, airways, and to expand the chest wall and the lungs. In a few words, we can see the P-mask and P-vent are pretty much the same kind of thing. So we can think of the vent like artificial muscle or something that is going to be replacing the work of the muscles. In the middle, when the patient is awake and start interacting with the patient, we can see that we have P-vent and P-mask. The whole patient-ventilator interaction requires both of them. When the patient is paralyzed, there's no P-mask, so we cannot speak about synchrony of desynchrony, because in order to be synchrony of desynchrony, we have to relate 2 signals together, P-mask and P-vent. When the patient is breathing spontaneously, there is only P-mask, there is no P-vent, so there's no desynchrony possible. The only desynchrony is going to be when the patient is connected to the vent. In that case, we're going to be relating the neural inspiratory time to the mechanical inspiratory time. Let's go to the next one. Now, after presenting this, we can say that a mechanical ventilator is a machine that assists the patient by providing all or part of the work of breathing. There is another function also that let us increase the baseline upon which the breathing process upon which the whole process of breathing is carried about. So this machine that that initially has to do all and later on can do part of the work of breathing, in the worst of the cases, when it doesn't work properly, it can impose work of breathing on the patient. When we intubate a patient and connect the patient to a mechanical ventilator, we create a system. This system is composed by the patient, the endotracheal tube, the tubings, and the machine connected to them, which is the mechanical ventilator. A person that has a respiratory center that is not working at this present time is going to be replaced by an artificial drive, which is the one in the vent. There's no perfect synchrony when we connect a natural controller with an artificial controller. When we connect a patient to a mechanical ventilator, there's always going to be some sort of desynchrony, some sort of delay. Nothing is perfect. Our work as a respiratory care practitioners or bedside care practitioner, whatever we are, whoever we are, is going to be to minimize the interaction of the dysynchrony between the patient and the machine. And to do so, we need to find the best mode and make the changes needed in time and manner, just to try to minimize those dysynchronies. Whoever is telling you that dysynchronies could be solved is going to be lying. It's not going to be accurate. The best thing we can do at bedside is try to minimize the dysynchrony. And to do so, we need to know our modes. When the RTs usually pull a vent at bedside, it's like we are putting a toolbox. In that toolbox, we have different tools that we're going to be using. When we get our toolbox, we're going to find a different kind of tools that we need to be familiar with. We need to know what they are for. We need to learn how to work with. We need to be an expert. And the best thing we can do when we open the tool, when we see all those tools, we usually first, we need to know the kind of job we're going to be doing, and after we're going to pick up a tool. There is something that we usually teaching, it's called the taxonomy of the modes. That it's a very interesting way to teach how all the modes are composed and work. The kind of work we're going to do could be condensed in three main goals, which are safety, comfort, and liberation. Safety means, since the patient is not able to breathe, we need to provide the minimum ventilation to the patient. And at the same time, we need to provide the minimum ventilation in a safe way without placing too much stress in the lungs. Time ago, we used to try to normalize gases, and to do so, we used to place too much stress on the lungs, and we can create a lung injury. Now we are trying to minimize that, and safety implies that we have to use modes that's in a safely way going to guarantee the minimum minute ventilation to the patient. To do so, initially we use modes composed of we call mandatory breaths, are modes that have a backup respiratory rate. Every time you intubate somebody, the first thing you set that respiratory rate. When the patient starts getting active, we're going to start seeing a little bit, maybe dysynchrony between the variability of the neural inspiratory time and the monotony of always the same mechanical inspiratory time. In order to improve the comfort, what we usually do, we liberate the I time and also the inspiratory flow to make it be closer to the natural variability of the respiratory drive. And we ended up with liberation. Liberation means that slowly the work of breathing that was initially done 100% by the vent is going to be not slowly, sometimes in a very rapid way, it's going to be assumed by the patient. So the three main goals are safety, comfort, and liberation. I can guarantee you that after intubating somebody, the RT is going to start using, are you guys all Servo-I users or Servo-U users? Yes, okay, all my pictures try to represent servo. When somebody gets a servo at bedside, after the patient was intubated, there are three modes that they're going to be using most of the time. It's going to be volume control, pressure control, or PRVC. The reason because they're going to be using one of those three modes is because all of them, they have a respiratory rate. We can see here pressure control, volume control, it has a respiratory rate, pressure control has a respiratory rate, and PRVC also has a respiratory rate. Between these three modes is going to be the one we're going to select, and now we need to define what is volume control. This is very important to define because in reality what we call volume control is flow control. That means that the variation of the inspiratory flow is going to be preset. The patient wants more or less flow, and the machine is not going to give it to him. The machine is only designed to provide the tidal volume using the different kind of flow shapes that we have available. In this case, it's a Hamilton. We have all these different kind of flow shapes. This is a Puritan Bennett's. This is the one you guys use, the Servo-I and Servo-U. So the goal of the machine is try to deliver the tidal volume following the kind of flow shape you selected. It's very important to know that in some of the events you set the inspiratory time, in another one you don't set the inspiratory time, but the inspiratory time comes from the combination of the tidal volume, the peak flow, and the flow shape. Very important that if the patient is passive, there's not going to be any kind of conflict between the inspiratory and the expiratory time. But when the patient starts getting active, the machine will not give the patient more flow, and that's when we flow desynchronous. This picture that you see here is the one most of the time I use to teach what is pressure control and why pressure control is more comfortable with a patient with variable inspiratory demands. The best example I could find is when you flush the toilet, the container at the back of the toilet, every time you flush it means that the patient exhales. You can hear just after that the water goes quickly up and starts slowly decreasing as the floater starts going up. The floater is the sensor. So if you guys want to set a pressure of 20, the machine gonna deliver very quickly flow to reach 20, and the goal of the machine is try to keep the pressure nearly constant until the end of the inspiratory time or until the cycle variable is reached. The machine doesn't know that there is a patient, or the machine doesn't know that it has to deliver a variable flow. The machine only knows that if the floater goes down, what the machine has to do is send flow to restore the floater to the previous level. That's why on pressure control, flows are variable, because the patient is going to be sucking the flow, and the machine is going to be delivering flow just to compensate that level of pressure. If you can see, compared to a volume control mode where the flow is preset, any mode with a variable, any pressure control mode that has the capacity to adjust the flow, to vary the flow, is going to be very comfortable for a patient with variable inspiratory demands that we can see right here. All the different flows of the flow waveforms. We can see right here on the upper part, this is a volume control mode, and you can see in every breath, the machine is to deliver the inspiratory flow waveform selected by you. And in the lower part, we can see this kind, the first one has a little bit like exponential decay, the second has a different flow, the other one has a little different flows, and this one has this concavity in the middle. Any volume control mode cannot do this kind of thing. That's why it's going to be more uncomfortable for a patient spontaneously being in volume control. Best comfort that a patient, the best comfort that you can give to a patient is being on a pressure control mode. When the patient starts getting awake, when the RT realizes that the patient is getting awake, 99.9% of the time, when the RT realizes that the patient is awake, goes to bedside and makes a change of mode, goes from pressure control, volume control, or PRVC to pressure support. And the question is, why do they do that? And the reason is because pressure support is a mode composed of spontaneous breaths. Like you guys are breathing at this time, nobody's telling you when to start and when to finish the breath. Pressure support is cycled by a percentage of the peak inspiratory flow, which is considered to be caused by the patient. And just remember, pressure support is a pressure control mode, so the flow has the capacity to vary. So not only the flow changes, but the inspiratory time is not preset anymore as before. Now it's going to be variable. You can see on this same pressure support mode, this is a Hamilton G5, it's called spontaneous. You can see the first one, how the inspiratory time is longer than the others. In pressure support, there's no set inspiratory time. So there's nothing that I have to fight if I want to take a breath, if I want to start it before, I want to start it after. Everything is freedom here. But still, we are getting closer to the natural variability of the respiratory drive, of the respiratory center, but we need to do some sort of fine tuning to adjust the cycling criteria. In these pictures, we can see the 4 phases of mandatory and spontaneous breath. I know that many of you are RTs and other ones are nurses. So first thing we need to know that the vent needs to know when to start a breath. we usually try to make the cycle variable, the triggering variables we use most commonly are pressure and flow. If the patient takes a breath and the pressure decreases, that's a signal for the vent to deliver a breath. It's a signal to say the patient is telling the vent, I want to breathe. The second one is flow. We make a flow circulate, and when the flow getting out is less than the flow coming back to the vent, that means that the patient wants to breathe. Those are the common signals. If none of them is present because the patient is not able to trigger, the trigger is going to be time. So that's why initially to achieve the goal of safety, we provide mandatory breaths. Breaths are going to be started every single. Let's say if you set a respiratory rate of 10 and the patient is not breathing, every 6 seconds the machine is going to deliver a breath. Later on, after triggering, we can see these are graphics of flow. Whatever flow goes on top of the baseline, that's the inspiratory flow. Whatever flow goes below the baseline, that's the expiratory flow. The inspiratory time starts from the moment of triggering, from the moment the flow starts rising, until the moment that the expiratory flow begins. And the expiratory time starts from the moment the expiratory flow begins until the moment the inspiratory flow begins. The end of the inspiratory time is called the cycling. In the first one, we see the a mandatory breath where the control variable is flow. And in the second one, we see a pressure control breath in when the inspiratory flow decays exponentially because the patient is passive. If a patient is active and his P mask is present, it's not going to decay exponentially. It could have any single shape which reflects the flow adjustment that, in order to keep the pressure nearly constant. In a passive patient, either when you control pressure, volume, or pressure, the expiratory phase of a passive patient is going to be, you're going to have an exponential decay. That means that it's going to decay exponentially from the plateau pressure until the level of PEEP. If you don't, of course, this exponential decay is going to be dependent on the time constant. If resistance is increased, it's going to decrease exponentially, but it's going to take longer to reach the baseline. If in the passive patient you see this exponential decay and suddenly you start seeing that the flow starts taking this direction, that means that the patient is using actively the expiratory muscles to push the air out of the system. So now we can see that we can have these synchronies at the beginning of the breath, during the breath, at the end of the breath, and during the expiratory time. We're going to be focusing now on the timing differences. The timing differences between the neural inspiratory time and the timing differences with the mechanical inspiratory time. That means that the time when our brain is sending the signal and the time when the machine is delivering the flow. Usually when we are at bedside, when I'm at bedside, I go with my stethoscope and I start trying to, I look at the patient, I put my stethoscope on top of the patient, I put my hands on the chest and one of my hands on the tubing, and I try to feel, listen, and hear what's going on, and that's the best way you can identify any kind of dysynchrony. I can tell you that it's very hard to look when the inspiratory effort starts and try to coordinate it, try to relate it to the beginning of the inspiratory flow. So the best thing that we can do and the best thing to make evident when the inspiratory effort starts is when we use the NAVA, the EDI of the electrical diaphragm, which is the signal that receives the signal that comes from the phrenic nerve to the diaphragm. So in this case, we can see the very good coordination that there is between this EDI, that means that the electrical activity is sending to the diaphragm, with the beginning of the flow is pretty much online. So I would say that the concept, since I told you before, the concept of perfect synchrony is utopic. A little bit of dysynchrony is not bad. So this starts at pretty much at the same time. If we look at the end, it's going to end up at the same time. This mode is pressure support CPAP. In pressure support CPAP, you are breathing pretty much on yourself, but you still need to open the valve and send the signal to stop the inspiration to the vent. The other signal we use to make evident the relationship between the inspiratory effort and the vent is the esophageal pressure. We can see here that we put a catheter on the esophagus, and we can see that when the when the patient makes an effort, expand the chest, and the esophageal pressure decrease, and you can see how the system gets pressurized in pressure support. And almost when the signal returns to this point, the expiration ends. That means that this is a very, I would say, almost perfect synchrony. The problems that I'm going to be displaying next is when there is any kind of, let's say, the inspiratory flow is out of phase with the reference signal, which is the beginning of the EDI or the end of the EDI, and the beginning of the deflection of the esophageal pressure. Now we can see here in this patient with a NAVA catheter, we can see how the EDI starts here before, and look when the inspiratory effort starts, way after that one. In this case, we can see that the machine triggers the breath way after the inspiratory effort, which is called normally late triggering. If we don't have a NAVA catheter like many of us don't have, and my intention by displaying a NAVA signal, the EDI signal, is to relate this thing at bedside. When you see this kind of pressure going slowly down, that means that the patient has a weak inspiratory effort, or there is the presence of auto-PIP that increases the work of breathing. In this case, we can also see that the NAVA signal starts here and also triggers a mandatory breath of pressure control. And since the breath has an inspiratory time, it's going to be ended up way after the inspiratory effort ends. This is what we normally call late triggering. The second, well, here we got more in detail what happened, the delay cycle, trigger delay. We can see how long is the neural inspiratory time and how short is the mechanical inspiratory time here. How one start one after the other. The second one, the mode is pressure control. We can see here that the inspiratory flow starts right here, and then the EDI, the electrical activity of the diaphragm, starts way before. We can see right here, we got overlay the EDI and the pressure signal, and we can see the difference right here. What happens here is that the vent triggers before, and it's followed by an electrical activity on the diaphragm. I don't know if you guys heard about reverse triggering. Any of you have ever heard about reverse triggering? Okay, I'm going to make it very simple. When the patient generates a signal, actively generates a signal, the machine responds by delivering a breath. In this case, this patient, the breath starts first and triggers a reflex activity on the diaphragm, which is called reverse triggering, because instead of the patient triggering the vent is triggering the patient. Most of the time, if you make an expiratory pause, and this happens also on brain-dead patients, we make an expiratory pause, and the electrical activity of the diaphragm disappears, because it's a cause effect. Every single electrical activity of the diaphragm is triggered by the mechanical breath. Later on, I got more examples of this, but you can see that this is called, we can call it early triggering, because the machine triggers before and is followed by electrical activity of the diaphragm. This is something that happens very often, and I want you guys to pay a lot of attention, because it, when you see something, like when you see ghosts, you start seeing ghosts every single time. I went to see this patient, and everybody was saying, oh, the patient is breathing fine, he's breathing fine, he's breathing fine. And I always get this kind of sensation like, I like to test what's going on. I'm like a doubting Thomas. And I got a sensation like, okay, I need to check if the patient is really the one triggering the vent. To me, this kind of thing is kind of weird. So I make an expiratory pause right here. And guess what? During the expiratory pause, I don't see any inspiratory effort. What I'm seeing right here is the heart. Those are cardiogenic oscillations of the airway that are cheating on the vein or tricking the vein. The vein thinks that it's the patient trying to trigger when it's not, it's the heart. Whatever trigger variable we use, pressure or flow triggering, the vein responds when they see a difference on those variables. But the vein does not discriminate where those alterations could come from. They could come from a trigger, they could come from a leak, they could come from the heart, they could come from many sources. And this is what we call false triggering. False triggering because the patient is not really breathing. This guy is breathing, the heart is breathing. You can see on the pause there's no inspiratory activity. Something I like to remark on the previous one, that usually cardiogenic oscillation causing auto-triggering or false triggering happens when you are using flow triggering. On the servo, when you guys are going to get the servo U, when you're using flow triggering of 1.6, 1.8, it's very sensitive to cardiogenic oscillations. What I do usually, I make the pause to confirm what's going on, and the next thing I do, I switch it to pressure triggering. You can see in this case here, the patient was on flow triggering. You can see the white line on the flow line. The servo U, the white line is going to be on the waveform that belong to the same triggering variable you are using, in this case flow. And here I switch it to -1. And you can see here how there's no inspiratory effort. Every single time it was the heart triggering the vein. And this could happen, believe me, it's very often it can trick every single one of you thinking that the patient is breathing. And on top of that, your gas is going to be way different when you realize that it's not the it's not the patient the one breathing. Now we have another mode called CPAP, and we can see the electrical activity of the diaphragm. The beginning seems to be pretty much, I would say, almost at the same time, but look at the end. The electrical activity of the diaphragm ends much later than the vent cycle. This is what we call early cycle. Early cycle means that the vent shut off the inspiration before and the inspiratory effort continued after. Sometimes if the inspiratory effort is very strong, it could trigger another breath. But a typical sign that we can see on the expiratory waveform is this kind of notch, this kind of upward concavity. That means, as you can see right here, that the effort triggers, the electrical activity of the diaphragm triggers the vent and continues after. And the normal expiration that's supposed to have like little, I would say, exponential decays is sucked up by the inspiratory activity. The next one here, we can see when the vent cycles after the electrical activity of the diaphragm. That means that's something that we call late cycling. We can see that the electrical activity of the diaphragm goes up, and the vent should have been cycled right here. On pressure control, we have a set I time. In this case, the mechanical set I time is longer than the neural inspiratory I time. And we can see this increasing pressure at the end. That means that I would say the patient is trying to exhale, the system is trying to go back to PEEP, and the machine doesn't let it do so until the inspiratory time is elapsed. In this case, what we have to do is try to shorten the inspiratory time just to make match the mechanical inspiratory time with the neural inspiratory time. And something else we can do if the patient is active and we can see it's triggering here, why don't we switch it to pressure support? Pressure support has a variable inspiratory time, so we can liberate the set inspiratory time, and the drive with a natural variability of inspiratory time is going to be stop conflicting with the monotony of the same mechanical inspiratory time. This is something that when I told you that when inspiratory effort starts after a machine trigger, what we can call reverse triggering. Reverse triggering could cause a reflex diaphragm effort that if it is strong enough, it could trigger another breath. In this case, we can see that the first breath, volume control, and then the reverse trigger 2 breaths. We can have here the flow waveform, and we can see that every single breath, the volume waveform resets to 0. So we don't have a very rough idea or a very good idea how much is the volume that kind of triple tidal volume could cause. There is a little exhalation in the middle, but if we rearrange the graph, flow goes in, a little bit goes out, flow more volume goes in, a little bit of volume goes out, and more volume goes out, we can see that the total tidal volume caused by this almost doubles the set tidal volume. In this case, if you are trying to get any kind of protected mechanical ventilation strategy, you're going to see that it's going to be violated because the tidal volume is going to be twice, not 3 as it appears because there is some exhalation in the middle. But you need to be aware of how the volume going to look like versus how the machine displays the tidal volumes by resetting every single breath to the beginning of the volume. What we can see now here is something that is seen during the expiratory time. The patient is trying to make an inspiratory effort here. You can see how the expiratory flow that's supposed to be slowly decreasing here goes up because of the inspiratory effort. This is what we call ineffective inspiratory effort. Usually they are seen during the expiratory time and happens on patients with obstructive lung disease and patients that are also under sedation and the inspiratory effort is kind of weak. In this kind of effort is not enough to trigger the vent, but in order to trigger the vent, it has to be able at this level to overcome the level of PEEP at that point. Sorry, level of auto PEEP. At the beginning, I started talking the relationship concerning the work of breathing. When we intubate somebody, 100% of the work of breathing is done by the vent. When we finally extubate somebody, 100% of the work of breathing is done by the patient. And in the middle, there's going to be some sort of relationship of working together, pushing and pulling between the vent and the patient. Hopefully, the best synchrony would be both working together. But sometimes there are going to be conflicts between them. One is pushing when the other one doesn't want to pull, and one pull when the other one doesn't want to push. This CMB in a Hamilton G5, that is what you guys know on the servos as volume control. We can see here the volume control, the flow waveform is constant, rectangular, or square. And here I don't see any kind of activity of, there is no PMAS. It's a total passive ventilation. 100% the work of breathing is done by the machine. Here we can see how the pressure increases when any muscle activity is absent. And here we can see how this pressure waveform looks different than this one. That means that there is an inspiratory effort here that is sucking, I would say, this is what you guys know as flow desynchrony. The flow goes down. We call it flow shifting because in this scenario, the vent is doing less work and the patient is doing more work. And you can see how this work shifting goes almost, if the PEEP here was 20, the patient is sucking almost down to 0. It's doing a huge inspiratory effort just because volume control is a mode designed to provide the flow that you said. If a patient wants more or less flow, the patient is going to be sucking almost against a closed airway. So you can see how uncomfortable the patient is, and you're going to see that the machine is doing less work and the patient is doing a lot of work. It's almost you're going to see the patient working a lot. What normally people do in this case of scenarios, they switch to volume to pressure control. By switching to pressure control, you liberate the flow, but you need to be careful because if the patient is any kind of, it's an ARDS on the early stage that needs to be sedated, and you might liberate the flow. When you liberate the flow, the tidal volume goes high, and it's not going to be protective anymore. Now we're going to talk about another mode that has pretty much something that looks the same. It's PRBC. On the first picture, we got a PRBC set on 600, tidal volume 320, respiratory rate of 12. And you can see that the patient is triggering, but the force the machine is doing to push this 320 is going to be 26. It's going to be 26 the peak pressure, and the PEEP is 12. So 14 is the pressure that is doing to generate that tidal volume. PRBC is not a volume control mode. In PRBC, the flow is capable of changing. What PRBC does is a self-adjusting pressure control mode. Every single breath is a pressure control. You want to deliver 320, the machine delivers a pressure control breath, measure the exhale volume. If the tidal volume is more than 320, the next breath, the pressure is going to be lower. And it's going to be lower until it gets pretty much around the 320. When it sends a pressure control, the exhale tidal volume is less than 320, the next breath is going to be with a higher pressure level until the tidal volume is pretty much, we can say that on PRBC the tidal volume is reached on average. So we call PRBC not a volume control, we call it a self-adjusting pressure control with a target tidal volume. We can see here that I told you that we got a PEEP of 12, PIP 26. So the pressure necessary to push the tidal volume was 14 at the time. Later on, hours after, I came to see the same patient that I left on PRBC, and look, the pressure looks different. The peak pressure is 16, and the PEEP is 14. I would say that the pressure, this looks pretty much like CPAP, and the real pressure ventilating this patient was 4 to 5. I looked at the patient, and the patient was struggling like crazy. The mode was behaving in the way it was programmed to behave. So the patient was experimenting any kind of distress, was sucking too much air, more than 320, so the vent was thinking that the patient is improving, so the next one is going to be less pressure, and less pressure, until the patient is doing pretty much the whole work of breathing. In this mode, that initially was designed for a patient that slowly is improving, to decrease the level of pressure to a minimum of pressure support plus 5, meaning that it's weaning slowly the patient, it's not going to work fine when the patient is trying to struggle, is on respiratory distress, because instead of giving the patient more support, the vent is decreasing the level of support. This is what we call work shifting. Slowly the machine is shifting the work of breathing to the patient. The same thing that we compared before, you can see a different patient on a different machine, and how the PRBC went from this level of pressure to this one, and this patient was also struggling. In a few words, when P mass goes down, when P mass goes up, P vent is going down. That's why you need to be very careful when you select this kind of modes to be sure how the patient is breathing. This mode works fine on patients, I would say, cabbage, that's going to be an easy weaning, so very fast. But on somebody that gets suddenly trouble breathing, they are not working really very good. And another mode that has the same kind of working principle is volume support. Volume support is like a self-adjusting pressure support with the goal of trying to deliver a certain tidal volume, and has the same behavior. When you see this and the patient is struggling, best thing you can do is switch them to pressure control, or I would say pressure control, because the level of assistance is going to be the same versus this one that is going down. On the servo U, something that we're going to see in the workshops is a mode called auto mode. Auto mode gets together pressure control and pressure support. When the patient starts breathing spontaneously, transition from pressure control to pressure support. You can set independent levels of the same level of pressure control support. By switching quickly from pressure control to pressure support, it removes the mechanical inspiratory. In this case, this patient is breathing kind of fast at the beginning, and we can see that we got a PEEP of 8 and pressure support of 6. The total pressure support supposed to be 14. Here we got a PEEP of 15. And this wave from here is supposed to look square, and look how we see all this concavity. That means that the ventilator is not capable to pressure the airway fast enough in the same way the patient requires. We all, like I told you before, pressure control, any kind of pressure control, pressure support modes, the flow is variable. And all the manufacturers advertise that their flow is so high, but you're going to start seeing this very often. How it happens, I still don't know, but I can tell you that this difference in pressure, it's work that the patient is doing that's supposed to be done by the machine. When we talked before about reverse triggering, I told you that reverse triggering reflects the diaphragmatic contraction triggered by the machine. It follows machine triggers followed by a diaphragmatic contraction. It happens on some breath or happens in every other breath. In this case, we get machine trigger followed by something that looks like a spontaneous breath. This is a diaphragmatic contraction. It doesn't happen here, machine trigger, and we see this notch here, meaning that there was a spontaneous activity here. It doesn't happen here. It happens here. It happens here. If you continue on this patient like this, you're going to see that there is some activity. But here, I made an expiratory pause. So where is that spontaneous activity that we've seen here? When we made the expiratory pause, we confirm that the reason of this spontaneous activity is associated to the mandatory breath. This is a clear reverse triggering case. And we can see how important it is to use an expiratory pause to rule out or confirm the patient's activity. This is two different kind of expiratory pause. I'm doing this one. You can see how here is triggered by flow. And when I make the expiratory pause, there's no effort. There's nothing. That was the heart triggering the vent. And here on the left, we can see that it was on pressure support. But when I make the pause, I can see the deflection. This one here, it was the patient triggering the vent. So my suggestion to every single one of you, when you go to bedside, don't trust on the vent. Don't trust that the patient is triggering. Be doubting Thomas to the end. Make expiratory pauses and confirm if it is the patient triggering or it is the heart triggering. This is a real case, a real patient that happened to me last week. I was at bedside. We got a respiratory rate of 30, and we can see machine initiated, followed by there is a spontaneous activity here, and you can see how it extend after the end of the inspiratory time. It's on every single breath. This is reverse triggering. Usually, I told you on the previous one, I made an expiratory pause and nothing happens. So on the I made an expiratory pause to see what happened, and I realized that, wow, there is an inspiratory effort. So I measured the distance between the inspiratory efforts and divided by 60 and gave me a respiratory rate of 20. Here the patient was on a rate of 31. So I started thinking, well, maybe we are trying to impose on the drive on the center of the patient a respiratory rate that the patient doesn't want. So what I did, I decreased the respiratory rate to 20, and later on, look how the mechanics improved. We were forcing a respiratory rate of 30 on somebody that wanted a respiratory rate of 20. Sometimes we can do it. Sometimes the gases doesn't let us do this thing, but this patient improved dramatically. And you're going to see later on another graphics the causes of reverse triggering. This patient here has a NAVA catheter. You can see the EDI flat here. So, and you can see that these breaths are initiated by the patient. Sorry, it gave us the impression that it's initiated by the patient. But when we see the NAVA catheter, the EDI is flat. So what is triggering this breath. I make an inspiratory pause, and you confirm also the cardiac activity. So always inspiratory and expiratory pauses to measure plateau or whatever can give you signs or hints about what's going on or about who or what is triggering the vent. This is a Hamilton vent that gave me the opportunity to display on the vent screen the same kind of waveform you see on the pulse oximetry. And you can see all these oscillations on the expiratory, on the flow, on the pressure waveform, and you can see that every one of them relates to the pulse. So you can see how these things really are the heart beatings. This is another, we have here an esophageal catheter. You can see during passive, these breaths are supposed to be triggered by the patient, this one by the patient, this one by the patient, and the rest are triggered by the machine. We can see the esophageal catheter when the machine is triggering goes up, means that it's pressurizing the chest, but it's followed by a little, with the pressure going down, that means that there is an inspiratory effort. This one is passive, the esophageal pressure goes up. The one is passive, goes up, and suddenly goes down. And this one goes up and down. That means that the machine initiated breath trigger a reflex contraction of the diaphragm. And we can see how bad they are. You can see how the transpulmonary pressure is on the passive one, and look how high is the transpulmonary pressure, which is the total pressure distending the lungs in the reverse trigger breath. This is why it's very important for us to try to make as possible adjustments in order to try to abolish or diminish reverse triggering. This is a case where we have a leak. You can see the inspiratory effort goes, the volume goes in, but not the volume goes up. And we got the EDI here is very, almost small contractions. When we fix the leak, you can see how the EDI start going up. And that means that sometimes any cause of auto-triggering could cause over-assistance and could make the diaphragm work less. Here, when we fix this thing, we can see how the diaphragm started working. We got 10 minutes, so I'm going to try to rush from here. Here, it's an auto-triggering or false triggering caused by the elastic recoil of the patient, of the circle. I remember this patient was a COPDer, that he was very sedated and started doing this thing, and I said, it doesn't make sense. So suddenly, I got the opportunity to see this, and in order to solve this, it was the system pressurizing and suddenly releasing the pressure and triggering another breath. In order to solve this, I have to play with sensitivity and go to -2 or -3. The patient wasn't sedated. There wasn't any kind of activity there. This is another pressure support breath. You can see that on pressure support, we adjust the cycle criteria based on the percentage of peak flow. Here we can see how the inspiratory effort is too big that goes beyond the end of the inspiratory, the end of the breath. And you can see how this expiratory flow spike is sucked up by the inspiratory effort. So in order to fix this, what we have to do is decrease the cycle criteria and make it longer, let's say from 30% to 20, 10, or 1% until we match the neural inspiratory time with the mechanical inspiratory time. Here we got another example when it was at 30%, and double triggering could happen also on pressure support. We can see when we went to 1%, we removed the reverse triggering, but we still have a little of expiratory activity here. This is something, a very important thing that happened to me. Happens very often when I'm at bedside. I'm the kind of guy that tries to go at bedside and try to improve the way my patients breathe. And sometimes I feel one of my biggest frustrations are those patients, like there's nothing you can do, any adjustment doesn't work. And suddenly I call something desynchrony fatigue, because I start walking by the room, I start looking to another side because it's painful seeing the patient breathing like that. And situations changes and never gonna be the same. Whatever changes you do, 5 minutes after, or whatever you try to fix in a patient, 5 minutes after could be the worst. That happened on this patient. You can see on pressure support, it's very well in synchrony. I walk by 3 minutes after, and you can see that here start doing this kind of stuff. There is some dysynchrony. In a few words, nothing, no synchrony is perfect. Everything requires adjustments, and most of the time this manual adjustment that we have to do is replaced by automatic adjustment made by the more advanced modes. My whole presentation was questioning patient ventilator interaction. We can see all the publications, every single publication come about patient ventilator interaction. But from my perspective, it's not patient ventilator interaction, it's operator patient ventilator interaction. And the reason is because the operator is the one that selects the mode. The operator is the one that programs the mode. The machine only follows the command that this guy asks we are doing. In a few words, if we don't select the mode properly to adapt to the condition of the patient, if we don't make changes properly, if we are not at bedside all the time, this interaction is going to be bad, and it could be caused by us. And at the same time, if we are ready to be at bedside, we could solve the kind of interaction. So we could be the cause and the solutions for every not ideal interaction at bedside. That's why in reality there are operator ventilator patient interaction. And that's why our work at bedside is very important. The synchrony is unavoidable. We have to minimize the synchrony. In order to do so, we need to know the mode we use, how it works, how that mode is going to be interacting with the patient, and with things changes, what changes can I do, and how fast can I do the changes. If we have to do work on the floors, or we go on lunch, active patient that was on pressure control fine before, on a rate of 20, for an hour 30 minutes lunch, is going to be breathing 600 breaths, uncomfortable because maybe wants a different night time, shorter, longer, and the time we are away is the time this patient is going to be struggling. And every single detail on those breaths counts. That's why we are very important, and that's why more advanced modes, when they identify that the patient is breathing spontaneously, they just go advance the patient automatically from pressure control to pressure support, to volume control to volume support, to PRVC to volume support, and keep the patient breathing spontaneously. Why? Because they want to remove the monotony of the same inspiratory time conflicting with the variability of the neural inspiratory time in the name of comfort. More advanced modes going to be doing all those changes that we cannot do at bedside because we are far away, because we have to do treatments, because we have to do so many things, and it's going to be saving the patient a lot of uncomfortable times. Later on in the workshops, you're going to see a great mode you have in your servos, and you're going to get on the servo use, which is auto mode. Auto mode recognizes when the patient starts triggering and transitions to pressure support. And if the patient becomes apneic, it goes back to the previous mode without you doing nothing, and something very important, without alarms. Every time you put somebody on pressure support, you put your alarm on 20 seconds, it's going to be an audible and visual alarms, and it's going to go back to the backup apnea mode alarm. So auto mode does the whole thing without alarms, transition the patient fast, and at the same time gives the patient, follows the goal of safety by transitioning the patient back. So no alarms, no places, no more alarm fatigue, from the side of the vent. This is very important. These machines don't have brain. So you have to know when to make adjustment, you need to know how the mode works, you need to know how to properly do all your adjustments. And even if the more advanced the mode is, the more you need to know in order to identify when the mode is not working properly, and in order to identify the changes. So in a few words, you guys are very important, but you are very important as much, and you need to learn how every single mode works, the detail, the physiology and the anatomy of every single mode, and make changes fast enough. Because like I told you, I started asking you, take breath, take a variable breath, take different breaths. We all were fine. Our patient is struggling 600 times per day, 700 times per day. At the end of our shift, 1,000 breaths. We need to avoid this thing, because when the addition of every single details and they were talking about the traumatic stress disorder. How do you imagine how bad it is struggling on every single breath? We were talking about the drop of water when you torture somebody with a drop of water. Every single breath that we hear, we are blessed because we are not thinking about that. They know. And our goal at bedside is try to minimize those kinds of desynchronies. That's my countdown. Geez, that first time I'm on time. Just turn. No.
Thank you so much. Hello, there we go. What questions do we have for Ari?
Oh, see, man.
So we're going to break for lunch. We are going to start our afternoon sessions promptly at 1:15. Please keep to your sessions. Our rooms, particularly for the mobility ones, are in patient simulation rooms, so they are very lifelike in the size of them. And so those groups that you hopefully all have your assignments still, yeah, hopefully. Those assignments are really important so that we don't like put two groups together and stuff, because then we won't be able to put people in all the rooms. So lunch is out there. These first two rows, we're actually going to scooch forward. So if you're sitting in these two rows, move your stuff, because we're going to break this room out a little bit. And then lunch is in here. Well, lunch is out there, but eat it in here. So, and then we'll start promptly at 1:15. There are two sessions that are down here on this floor. Family-centered rounding is in this one, and the Michigan lung ventilator interactions are in room 130. Everything else is upstairs.
We want to exit out this door.
Exit out the front door, please. The front door.